Yep, that's the first time using it. Welcome to the regular meeting of the Public Health and Safety Committee for August 7th, 2024. My name is Jason Chavez, and I'm the chair of this committee. Before we begin the meeting, I want to offer a friendly reminder to all members, staff, and the public that these meetings are broadcast live to enable greater public participation. These broadcasts include real-time captioning as a further method to increase the accessibility of our proceedings to the community. Therefore, all speakers need to be mindful of the rate of their speech so that our captioners can fully capture and transcribe all comments for the broadcast. We ask that all speakers moderate the speed and clarity of their comments. We will also be using a timer today because we have a package. I want to let these members know. At this time, I'll ask the clerk to call the roll to verify the presence of a quorum.
Councilmember Payne.
Aye. Or present.
Rainville.
Present.
Ellison.
Here.
Palmisano is absent. Vice Chair Wansley.
Present.
Chair Chavez.
Present.
We have 5 members present.
Let the record reflect that we have a quorum. With that, the agenda for today's meeting is before us. There are 7 items on today's consent agenda. Item number 1 is passage of a resolution amending 2024 R212 entitled Amending the 2024 General Appropriation Resolution passed on July 1st, 2024 by updating the Funding and Revenue Code. Item number 2 is authorizing the submittal of a grant application to the U.S. Department of Justice National Sexual Assault Kit Initiative in the amount of $2.5 million total for DNA testing, investigation, and prosecution of sexual assault evidence kits. Item number 3 is accepting a grant from and authorizing an agreement with the DWI Court of the State of Minnesota 4th Judicial District Court in the amount of $34,104 for a police liaison to the DWI Court and DWI Defendant Monitoring Services. Item number 4 is authorizing a joint powers agreement with Hennepin County on behalf of its Human Services and Public Health Department in the amount of $133,000 and $33,000 for the 2024 term and $400,000 during the 2025 term for the 5 full-time embedded social workers employed by the Hennepin County. Item number 5 is authorizing a memorandum of understanding with the Metropolitan Police Department for Washington, D.C. Item number 6 is accepting a grant from Hennepin County Health Tree Canopy Program. And item number 7 is authorizing the submittal of a grant application to the United States Department of Agriculture for composting and food waste reduction grant to expand strategies to prevent waste food. That was a long list. Are there any discussions on these items? No? All right. Seeing none, I will move to approve the consent agenda. All those in favor say aye.
Aye.
Those opposed say nay. That carries and the consent agenda is approved. Members, with that, we'll move on to our 4 remaining discussion items. Our first discussion item is receiving and filing a presentation from Martin, the Senior Director of Emergency Medical Services for Hennepin County, relating to their work on public health and safety and the partnership between Hennepin County EMS and the Minneapolis Fire Department. I'll invite Assistant Chief Melanie Rucker from the Minneapolis Fire Department to introduce the director.
Good afternoon, Chair Chavez and committee members. I would like to introduce Chief Marty Shearer and Medical Director Simpson from Hennepin County EMS.
Welcome.
Thank you very much. I have a PowerPoint presentation I'll pull up here.
Thank you.
Welcome. Thank you very much for having us. I'm Martin Shearer, EMS Director for Hennepin EMS, and with me is Dr. Nick Simpson, and we just have a brief presentation. I know you have a pretty full agenda, so we'll try to go through it rather quickly, but please stop us anywhere along the way if you have any questions at all for that. So Hennepin EMS is more than just the city of Minneapolis. We cover 13 other communities, mostly western Hennepin County, and we have about 1.5 million people that we protect in our service area. So this is a picture of our leadership team. Most of us are pretty new. Most of us are about 4 to 5 years been here at Hennepin EMS, although we all bring a lot of experience before we came here to Hennepin EMS. and then I'll let Dr. Simpson just, talk about his medical direction team.
Sure. Thank you, Chief Shearer. So, yeah, we have a team of 6 EMS medical directors, so 6 physicians that help oversee the medical care, medications, the protocols, and the provision of care. And we just, within the last year or so, added an EMS pharmacist, a clinical pharmacist, which has been instrumental in making sure that we have the most up-to-date guidelines and protocols and have the best handle on literature and understanding of the pharmacy side. Keep going. So just very briefly, most folks are familiar with the concept of a cardiologist or a GI specialist as a subspecialty of typically internal medicine. EMS is now a subspecialty of emergency medicine, and so all of our EMS physicians have gone through that process. So we've all completed our residency in emergency medicine and then a year of additional training to be trained specifically and then board certified in EMS. So we understand the way that we can translate that emergency care into the field, into the pre-hospital setting. And it's really very instrumental to understand the systems and the processes and how everything sort of works together. At Hennepin, we are a teaching institution, as you all are likely aware. So we have residents and also fellows. So we have emergency medicine residents they get their education from Hennepin EMS to a degree with the EMS side, as well as our EMS physicians. And then we also typically have one fellow who has completed their residency and doing that subspecialty training. And in 2025, we'll be adding a second spot. So we'll have an opportunity for 2. All right.
Thank you. And most EMS organizations have maybe 1 or 2 medical directors. We're lucky we have 6. And the pharmacists, I think we're the only ones in the country that we know of so far that have our own pharmacists, which has been really good, especially with a lot of drug shortages coming up. She's able to kind of predict what the shortages might be, give us some substitution medications or different formats that the medications come in. So it keeps us always totally equipped to handle the calls. So Minneapolis, 80% of our calls are Minneapolis. This is just, I pulled the data up. So just in the month of July last year, we had 6,500 EMS calls in the city of Minneapolis. Of those calls, 5,397, so about 5,400, were Code 3 calls. So Code 3 calls are the lights and siren, the emergency calls, which are deemed life-threatening by our dispatchers. And then we have Code 2 calls, which are deemed less life-threatening. They might be a foot pain that I've had for a week or something like that. So we do about 1,100 of those a year as well, too. And then of those calls, we generally transport about 70% of those people to the hospital, so about 30% don't get transported, and about 45% of those go to HCMC, so that's not the only place we go. Downtown, we take a lot of people to Abbott and Children's as well, but a variety of hospitals we go to. But our response time is really good. City of Minneapolis, it's almost always under 7 minutes. Last month it was 6 minutes, 44 seconds, and so we have a great response time. And as you know, we have a really good rapport and a response with the police department and the fire departments as well. Some of you have ridden along with us and seen how the interaction between the police, fire, and EMS and how it's such a really coordinated group effort. And it's just amazing that 3 organizations that are not physically tied together can work that well together. So a lot of you know this, but we do more than just the emergency medical service. We also have a group of community paramedics that make house calls, essentially. They help people that are generally homebound and would be using 911 services if they didn't have the community paramedics. And so they do a great job of taking care of them. Great success story is there was a person that was too sick to leave the house, too sick to get a transplant. Our community paramedic people spent about a year working with them, and then she got healthy enough to get a transplant, and now she's living a healthy, productive life out of the house. So it's really some good stories from them. We also have our own dispatch team, and then we have some special operations and training team, and we'll talk more about those in a little bit. As I mentioned, we have the tiered response, so the police, fire, the paramedics, the ambulance. Kind of going to go through these rather quickly. We have a new group of paramedics that we call advanced paramedics, so P3 paramedics. A group of the paramedics came to us and said, hey, we want to do a little bit more, and so we've trained them on their own time. They volunteer, and they do a lot of additional training with our medical direction team. They do a lot of advanced airway, a lot of medications, equipment, and I'll let Dr. Simpson describe briefly some of the work they're doing.
Sure, yeah. One of the things that this group helped us pilot was ultrasounds in the ambulances, and now I'm happy to say that we have an ultrasound in every ambulance. So anytime a Hennepin EMS ambulance shows up, we have the ability to get some initial diagnostic information that was not previously available. And that is another unique thing to our service. It's a great way to offer some of those initial diagnostic modalities from the emergency department out into the field. And so this group helped us pilot that, a number of other medications, and then really has a very high level of airway management and sort of critical care at the most sick of our patients.
And then we have a group of paramedics who are trained primarily work for the fire departments, and they do a lot of technical rescue. This group right here in the pictures are working with the Minneapolis Fire at the U.S. Bank Stadium, so they do a lot of high-angle, low-angle rescues, confined space, those type of events. And then we have a group of our paramedics who work with law enforcement. They do a lot of special event training, a lot of high-risk warrants, and they're once again specially trained to work with law enforcement partners. Something new we started last year is our water rescue paramedics. They work primarily out on Lake Minnetonka with the Sheriff's Department, and they perform a lot of rescues that used to take a long time. They used to have to bring them in the boat, take them to shore, and then our paramedics would work on them. Now we're right on scene, right out as we pull people out of the water, we can provide life-saving work on them. We have a group of dispatchers that are able to move around if we have large incidences. We also bring a team of dispatchers to U.S. Bank Stadium and other large stadiums when we have big events. We have about 70 people that will work a Viking game on the field, so we have a dispatch team there. And then mental health has been a big issue with all first responders. We started our own peer support group along with other professionals, but this is a really, really impressive part of our mental health program. The peer support group is really a valuable part of our team. Our paramedics are very comfortable talking with them. It's very, very confidential, all the work they do, and this has helped us get over some of the challenges of being first responders. I mentioned our community paramedics. It's kind of a bridge between primary care and the hospital. And then we do a lot of review. We're focused on constantly improving, and our latest survey showed us the third best EMS agency in the country. If you look at our survey results, of a 98.99% result of a survey, and that number would be much higher. I think I mentioned it last time here, but we continue to get low scores in the ride of our ambulance. They're bumpy roads, I guess. And that's really the only low score we get. And a typical day in our EMS agency is about 260, now we're up to almost 300 calls a day. That's about a call every 5 or 6 minutes. Generally about, like I said, 170 transports. Our dispatch gets even more calls, over 1,000 calls a day. We get a couple cardiac arrests a day, several strokes. We usually have a structure fire standby. Overdoses and cardiac arrests, because of overdoses, have driven our call volume way up. That's about 25% of our calls now are mental health and addiction-related type calls, which is a very big increase from about 4 or 5 years ago. Occasionally we get a baby not breathing, and the person in crisis calls is very high. And I'd like to say thank you very much for your BCR team. They work really, really well with our team. They're very effective, and it's been a great success program, if you ask me. I think it's fabulous that we do that. I think in the future, most large urban areas will see a police, fire, EMS, and then some type of mental health response team. So good job on that. Talk about training a little bit, Dr.
Sure.
Simpson?
As mentioned, we train not only residents and fellows, we have medical students, and just yesterday we were talking to some high school students and college students, so lots of training at every level as part of Hennepin Healthcare and Hennepin EMS, and so we have lots of different outreach events sort of tied to this as well, with specific groups of folks that are interested in going to medicine. Lots of different options here. I won't go through all of these necessarily, but some of the ways that we've tried to increase opportunities for people that live and work in our communities are, we have the Pathways program in combination with MFD that's been very successful in getting folks trained up to that EMT level. And then we have the paramedic trainee program where EMTs can be employed and go to school with that employment, so they're paid to go to school, and that's been a great way to offer opportunities to folks from our communities, as well as increased the diversity of our workforce. It's just something that we're actively trying to work towards. Anything else you want to add there?
Yeah, no, these programs have, I'm happy to say we are probably one of the only large EMS agencies in the country that's fully staffed now. There's a national and statewide shortage of paramedics, and these programs have brought us really, we look out for high caliber, high quality people, and because of that, we've built up our workforce we're fully staffed now, and we have a waiting list of people work there, and when the good things like that happen, so more and more people want to work for us, and our diversity is dramatically improved. We have a lot of great people on our team now, and it's really actually turned into a fun place to work. Where before it was a challenging place to work. It's always been challenging. It still is challenging, but now it's kind of fun too. So we have a really good team. And so we have a lot of new technology and new equipment, a lot of medications. I'll let Dr. Simpson talk about some of those.
Sure. I already mentioned the ultrasound devices, which we don't have to rehash again. But one of the things that we may have talked about with the council before is the interpreter app, which has been quite nice. As you all are, I'm sure, aware, there are many different languages spoken in Minneapolis, and it is not realistic to get an in-person interpreter, which would be wonderful, at every scene. So what we've been able to do is work with our operations folks, our IT team, so that we can, with a push of one button, all we have to know is the language, or if the patient wants to select the language written in that language, they can do that. And with one push, you're connected to a live either video or audio interpreter of over 300 languages, which has been a nice way to, again, lower barriers to care, especially for some of our folks that have been underserved because of that language barrier. We can come back to the double sequential, which is just sort of a new way to utilize a novel technique to defibrillate patients who are not coming out of difficult rhythms. Lots of working with other services. So Minnesota Task Force 1 is the urban search and rescue team at the state level. A number of our paramedics are part of that for the medical asset. Do you want to talk about the BLS transport program?
Sure. So we saw, once again, a high increase in the number of calls for what we call non-life-threatening calls, basic life support type calls. Many services in the country have got a basic life support and advanced life support with the paramedics. And so we started a basic life support program about this time last year, and it's worked out really well. It takes some of the pressure off our advanced life support people so they can go to the critical calls, and they can take some of the less acute calls that are not life-threatening, spend a little bit more time with them and do the right thing and just improve our customer service with them. And sometimes they lead to setting them up with our community paramedics for long-term care with our community paramedic goal. So the goal is to get the right resources to the right people at the right call at the right time and be really, really good about that. One thing I will talk about, Dr. Simpson will talk about, our Suboxone program for the opioid issue has turned out to be really, really, really positive. So I'll let you describe a little bit more about that.
For sure. And again, I'm preaching to the choir. I know that the opioid epidemic is not new to anyone in this room. As you probably know, Hennepin County has the highest number of opioid deaths every year in the state. And so we have a unique opportunity. And so starting in July of 2023, where we just passed our year mark, we have been able to offer to patients that are interested and that meet the criteria, offer Suboxone on scene, which again, in my mind is really important to lower barriers to care, to meet patients where they are and to offer an opportunity into treatment. And we did on average about 10 a month over the last 12 months, so just over 120 doses, which again, what it does is it offers people the ability to, if they're interested, stop using opioids in the way they've been using them and start into a treatment program that includes medications for opioid use disorder, which is Suboxone or buprenorphine. So that's been very successful, and now we are trying to spread that good word to other parts of the state and other parts of the country so they can learn from our experience.
Can you tell them a little bit what it used to be like to get Suboxone?
Yeah, so Suboxone as a medication, as a physician, it was previously the case that you had to go through a special training course, you had to have a waiver on your medical license to be able to prescribe it. There were a lot of hoops to jump through, and then if you did all those things, there was a limited number of patients that you could prescribe to. It was very tightly controlled, and I think it led to a lot of mystique around the use. Talking extensively with our addiction medicine providers, toxicologists, pharmacists, we've developed a safe way that is similar to other parts of the country. There are 2 other parts of the country that have done this. One is in New Jersey and one is in California. And so joining that sort of pioneering group, we've been able to do this in a safe way so that now if someone calls 911 because they've had an overdose and they received naloxone, that can be offered at that time potentially, and also if they just are experiencing withdrawal. And so lots more opportunities for patients to initiate that therapy that haven't previously existed, which has been great.
And so we're out in the community as much as possible at the Aquatennial, a lot of the fireworks events. Our team really enjoys being out there. We're at almost all the concerts that are in town, sporting events, professional sports, college sports as well. We do a lot. We work with our partners in the fire service and law enforcement, and it's been a great teamwork of all these people together to make all this happen. And I want to talk, I'll just jump to the next one. We share a lot of insights. Here's what I want to really focus on. So we've done a lot of changes, and then the question is, does it work? Does it make a difference? And we're happy to say yes. So the CARES data is a national study that looks at cardiac arrest, and it tries to compare as close as it can, apples to apples, how people are doing in their service area as far as it goes to cardiac arrest. It's one of the only studies that's out there that compares EMS agencies. So a lot of agencies put a lot of weight into this as to how they're doing compared to the rest of the country. And I'll let Dr. Simpson describe exactly what they do. But if you look at the bottom left number, 65.2% of our cardiac arrest saves is probably the highest in the country. It's unbelievable. If that number was 42, 45%, I'd be really happy. If it was 50%, I'd be really excited, but it's actually 65%, which is unbelievable. And that is not just Hennepin EMS, that's Minneapolis Police, Minneapolis Fire, and all of our first responders. We all work together. So that number is not just about us, it's about the whole system that we have. And it's a really, really impressive number. That's something all of you should be really proud about.
Yeah, absolutely. So just real briefly what this is, to try to compare apples to apples, this registry utilizes patients that have a witnessed cardiac arrest and initially shockable rhythm, and then that second line down, the bystander, gets some type of bystander CPR. And so it really does give a feel for how good the system is. It's not any one piece of the system, but the system overall. And so, I mean, we wouldn't have numbers like this if it weren't for partnership with MPD and with MFD in Minneapolis to really continue that professional CPR after hopefully a bystander started it, and then continue that high level of care in partnership as we take that patient in. So these are quite good numbers with again a lot of working together on scene and in training and discussions ahead of time. So this is it's a testament to the system working.
And I'll say a lot of you hear about Seattle, King County being the world's best at cardiac arrest saves and stuff. And when I look at their data, the highest number they ever had was 52%. So we're doing really well here. And then any questions before we kind of wrap things up here by anybody?
If you finish the presentation,
Sure.
Unless Councilmember Rainbow, you're leaving.
No,
Okay.
and I can wait.
Perfect.
Okay,
Let's finish the
sure.
presentation. Perfect. And then we'll go to Councilmember Rainbow.
Okay, and so some of the things look in the future, we hope to, Hennepin Healthcare hopes to design a whole new campus in the next several years, so we're working on doing that. We hope to expand some of our special operations team. We're doing what's called First On Scene training for the Hispanic community, which is done in Spanish, and we're trying to work with a lot of different cultures and languages to get people that they teach them basic first response thing. And that's one thing that CARES data did show is that we had a 30% bystander CPR rate, which is on the low side. If we could improve our bystander CPR rate to near the 50% rate, that would be a much better rate. So that's something we're going to work on as well. There's what's called Good SAM. It's a technology that we hope to use in the future. I'll let Dr. Simpson talk about that. He's kind of pioneered this in our area, and that uses technology, once again, to get the right resources to the right people.
Yeah, so I think we've spoken about this with some of the council members in the past. It is a technology we now have in dispatch, and we're working on ramping up use. I can share that just about a week ago, we were having trouble finding a patient who had a lot of barriers to care, was not familiar with the area, didn't speak English, and utilizing Good SAM, we were able to identify that person's location and then get the responders to their side and then begin rendering aid, which was based on the description of where they thought they were, I don't know that we would have ever found them. And so it was a great use of technology and a great way to, again, make things more accessible and meet patients where they are.
And so Good Sam is a pretty neat product where our dispatchers can say, do you have a cell phone on you? And they say yes, and they say, we'll send you a text message. Click on the text message, and then they can talk with them live and have the video screen, and they can see what's going on. They can show the dispatcher or a doctor what's really happening at the scene and before we get there, so it provides us a lot more information. And sometimes we can solve the issue over the phone, too, so it works out really good. We have a newsletter, which I believe most of you receive, and you probably heard about many of these things that we're doing as well already. And now we'll open up to questions, and I think we got through that at record speed. So
Yeah,
thank you.
awesome.
Thank you.
Thanks.
Thank you for that.
Yeah, thanks so much. I do want to let, if we can make sure that Councilmember Palmisano's attendance is noted, and I'll go with Councilmember Rainville.
Thank you, Chair. And thank you both for coming down today. It was a very concise presentation. It wasn't too fast, so we all can pick up that. But I'm curious, why are you fully staffed? What's your secret?
Yeah, great question. I get that calls from all over the country. So, we have our own paramedic program. And when I started about 4 years ago, I'm like, why do we have such a staffing issue if we have our own program? And a lot of our people in that program were coming in and then going out to maybe rural Minnesota or wherever, other areas. So we started the EMT to paramedic trainee program. We noted that we had a diversity problem. We had staffing problems. We had a lot of other issues. So now we offer to EMTs the opportunity to become a full-time employee, full-time wages, full-time benefits, and then they'll spend the next year, which is normally about a 2 or 3 year course, next year in a paramedic class. We are able to hire from a large pool of people. When we started that program, in the first 3 days that we opened that program up, we had 157 applicants. And so that program is supplemental to our normal hiring, but because of that, we got fully staffed. We started building a really good reputation, thanks to Dr. Simpson and his team, of piloting a lot of new programs and offering new opportunities for medics to do a little bit more advanced things. So now we're getting paramedics coming from all over the country that want to work at Hennepin EMS. Dr. Simpson and his team have published a lot of papers, and we're kind of becoming known as like the agency that is really on the cutting edge of EMS and medical care, and I think that's helping that, along with just hiring some good people, and people like to work with good people, and we raised our pay. We're some of the highest paid in the state right now, and that helps as well. So a lot of things, not one thing in general, but several things together.
Great, thank you. And I had the opportunity to do a ride-along, so I want to just thank both you, Doctor and Chief. The way you cooperate with our fire department, police department, I never would have guessed how well you all work together and how necessary that is. So hopefully you can host me for another ride-along after Labor Day.
Yeah, we'd love to. Yeah, I take a lot of legislators on ride-alongs too, and that's one of the first things they comment on is the great teamwork that the police, fire, and EMS all have with each other. They don't even need to talk to each other. Everyone just knows what to do, and the patient care and how respectful and well they treat our patients is really impressive.
Yeah. Thank you very much.
Thank you, Councilmember Rainville. Thank you both so much for being here. Really helpful presentation. Really helpful to know that you said 80% of the calls are in Minneapolis. That is important data for us to know. So really appreciative of the work that you all are doing to address some of the biggest concerns we have in our city. And Nick, we actually did a ride-along in March of 2022. So you actually drove me around, and I got to experience similar to what Councilmember Rainville did. And I think we were in downtown. There was a flipped car. There was a mental health response. There was overdoses, and it was an eye-opening experience. So just thank you for giving me that experience and knowing how tough this job is. So really important to figure out how we can be supportive of these efforts. I just wanted to make comments. Thank you for being here. I'll go. Sorry.
No, I was going to say I thank you for the opportunity, but I also want to add that even though we're not officially a Minneapolis department, please treat us like we're a Minneapolis department. You call Dr. Simpson, me, any time of the day or night, whatever you want, talk about any issues. I mean, we're just like your police and fire department. We're one of you, So, and if you're not happy with us, let us know. We want to make sure that we take care of people and we respond to you. You're our boss, so thank you very much.
Thank you so much. We'll go with Council President Payne, and then we have Councilmember Palmisano.
Thank you, Chair Chavez, and thank you all for being here. Really exciting to see the Suboxone program taking off. That's something that we've been really investigating, and how we could have a better response to the opioid crisis, and seeing that point of care happen is, I think, really, really important. My question, though, is for BCR, when we were originally designing it, one of the models that we were looking at was Cahoots, which I think is like one of the earliest direct response mental health programs out in Eugene, Oregon, I think it is. And my recollection is that that model had an EMS paired with a mental health professional, and now we know our BCR are 2 mental health professionals. There's not an EMS component to that necessarily. I think part of that was, our process for getting that launched was very much dependent on identifying a good contractor to work with, which ended up being Canopy Roots. And I think part of that kind of multi-jurisdictional coordination was a little bit challenging in the early days of that program. At this kind of more mature stage of that program, I'm wondering if you have any perspective on pairing BCR with EMS, if there's benefits to that, barriers to that thing. Is this something we should seriously be considering, or do you think that the current model is ideal?
Yeah, so I can share from the medical side. I do think there are significant benefits, potential benefits, to doing something like that, having the expertise of a mental health professional paired with that medical expertise. And this is, from the emergency department, I can tell you sometimes it's difficult to know if someone has anxiety or if they have a blood clot in their lungs, and it takes some testing and some nuance to parse those things out. So additionally, I think if there was a time in the future when we could have a collaboration like that, it would open up opportunities for medication options, as I think you're alluding to. From a clinical side, I think it's something we can continue to talk about. I don't know if you have any thoughts.
Yeah, I would say yes, but I would say also the current model is really effective. So if we did something like that, let's say we had maybe, I'm just making up numbers, but 4 BCR teams out there, maybe 1 or 2 of them had an EMS professional with, and the rest didn't. Because the system works really well the way it does now. The BCR team is really good at recognizing something that's beyond their scope, or something that's more of a medical issue than a mental health issue, and they call us. So the system's working pretty well, but yes, we could fine-tune it down the road, I think, as well.
That's great to hear.
That makes sense.
Yeah, that does make sense. Thank you.
And lastly, we have Councilmember Palmisano.
Thank you. And thank you for your partnership over the years. I've enjoyed being able to go and attend ride-alongs with you as well, and just learned a lot. Even though ages ago I was an EMT myself, it's a lot different now. Can you help us understand a little bit about the considerations on your mind as you deploy the P3 staff that you have? I think that's really exciting. How do you decide maybe what shifts or how to manage that higher level paramedic amongst your whole operation?
Yeah, that's a great question, and that's continual debate in our own organization is how do we best do that. So originally we decided that we would just kind of get volunteers to do it, and we got about 20, but I think we're over 30 now that want to do that. And so they're pretty well dispersed among the shifts. At one point we decided, should we send them on certain calls or not, but we're generally sending the closest rig, and more often than not, they do have a P3, but not always. And so we are thinking about, should we, put a little bit of thought in the deployment of where they go. But then also we have, paramedics that like to work with certain people, and so there's a lot of challenges to that as well. But it's something that we have thought about and we just continue to think about. But I'll let Dr. Simpson talk a little bit more if you want. But yeah, great question, and I don't have a great answer for you, but we have thought about what we're going to do. Yeah.
Yeah, for sure. So the program has evolved, I think, significantly since the inception. And as Marty said, initially it's who's interested, who's willing to dedicate that time, and over time, I think we've done a decent job of distributing who's working when, and we've, as Marty alluded to, we've talked a lot about, are there ways we could, fine tune that deployment in the future? Potentially, I think. As time goes on, we'll continue to discuss those things. But right now, it's they often will end up on the calls they need to be on, but there's not any specific deployment strategy currently.
But we kind of do. Our dispatchers will right now, they'll deploy special operations team paramedic to a high-risk warrant, and they'll deploy a tactical rescue medic to someone who's just down the embankment on the river or water rescue kind of thing. So we do that, and our dispatchers kind of do send P3 medics to what might be a pretty significant call, but it's also really difficult to predict if the call, on just a regular medical call, how the severity of the call is, and so it's hard to predetermine what level of training they do. But what the good thing about the P3 program is we've expanded most of their skills into our whole organization, and so they are generally now looking to do more things that are not experimental, but we're piloting different trials. Like, for example, ultrasound started out with just P3s, and now everyone does that. P3 started out with surgical airways and now all of our paramedics are doing that. So it's expanding our capabilities and our role. So we're proving what we can do out in the field a lot more with our P3 staff, and then we bring it out, roll out to the rest. But I think there'll always be a few things that the P3s do that the paramedics don't do, the other paramedics. But still, great question. I don't have a great answer for you.
No, thank you. That's helpful.
Great. Thank you both so much for the presentation. Really helpful, and we really appreciate you coming down here.
Thank you for having us.
Seeing no further questions, I will direct the clerk to receive and file that report. Our next item is receiving and filing a report from various national partners and organizations on trends, insights, and successes of violence prevention strategies that center public health. I will give Vice Chair Wansley the floor to introduce this item.
Thank you, Chair Chavez. So first, I just want to briefly speak to why Councilmember Chavez and I invited the groups that we will be hearing from shortly, why we brought them here today. And I hope my colleagues as well as the public can have, some very specific takeaways from these conversations. And we've talked a lot on this dais about the struggles that we've experienced, and it's no secret that over the last few years at the city, we've had some tumultuous and, struggling years when it's come to how we approach this promise of delivering on a new model of public safety that goes beyond policing. And it's very clear that systemic changes require bold investments as well as regular monitoring and evaluation and a variety of ways of ensuring accountability and transparency. And successful implementation of violence prevention strategies, they have a lot of evidence that backs them up and have help to demonstrate that they lower violence, that they lower crime, and have overall positive effects in the community. And many violence prevention efforts have been successful in cities throughout the nation and even here in Minneapolis at lowering violence and creating overall safer neighborhoods and communities. So I'm really hoping that today's presentation is just the beginning of a renewed commitment from the city to fully adhere to national best practices, as well as to prioritize violence prevention strategies as part of our new model of public safety. And these partners have a very successful track record. And I'm hopeful that we will lean into these partnerships as well as their expertise, especially when we have shown and demonstrated that we're having some difficulties in maintaining this particular work at the level of quality and professionalism it requires. So in advance, I just want to say thank you to our partners for taking the time to be here. I'm looking forward to further discussions and moving forward on additional action steps that you all identify in your very extensive presentation today. And I'm just overall grateful for your leadership and expertise in helping us find how we can make our city safer for all. So with that, I will pass it on to our partners to bring up their presentation and begin.
Welcome.
It is afternoon. I'm coming from the East Coast. Good afternoon. My name is Sunithia White, and I'm the Director of Strategic Initiatives with Cities United. Thankful for Chairperson Chavez and Councilwoman Wansley and others for allowing us to share with you today. So our presentation around building a comprehensive ecosystem to help identify, engage, and support those who are most at risk is a a compilation of partnerships between organizations with collaborative strategies that help cities do this work in advance to reduce violence in cities. So today we're going to define community violence, provide an overview of the CVI or community violence intervention ecosystem. If you hear us say CVI, it is just to shorten it up a little bit. And the partnerships required, offices of violence prevention, internal and external, group violence intervention, including community and law enforcement, and the violence interrupter credible messenger model. Also, the role of HVIPs. And we're hopeful today that once we go through all of that, we will have shared a presentation with you that makes that integration easier to understand. And of course, we'll welcome questions to further or opportunities to expand further on some of the things that we share today. So what is community violence? The National Criminal Justice Association defines it as the intentional use of force or power, threatened actual against another person or a group or community in a specific location that results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. But for those who live in community, it is often defined as not being able to go somewhere and feel safe, right? And that where you're going to be safe is often you want to be able to go to the park in your neighborhood. And so threats of violence in spaces where they should not have to worry about those things or worry about retaliation. The National Criminal Justice Association gives a much better SAT word definition. But as we do this work, we want people to feel safe in spaces. So the CVI, it is done to reduce near-term violence. And that is important as we talk about in the context of violence reduction, because prevention is necessary, right? But often with prevention programs that many cities or localities implement, those are things that we are planting the seeds in younger people or in communities that we will see the outcome on much later. But with CVI, it's that near-term violence. It's also specific, or the response is tailored and led in a community-centered way. Meaning that some of the interventions and things, for them to be effective, have to make sure they respond to the need presented in that particular incidence. And so to disrupt the cycles of violence and also to address retaliation. Some of the strategies that you'll hear about more in depth today are street outreach, violence interruption, hospital-based violence intervention, also shortened and we'll say HVIP, life coaching, peace fellowships, and violence-focused cognitive behavioral therapy. And so when we look at this with Cities United, we look at the wholeness of the ecosystem and often have folks think backwards. If you're working with a community or an individual who has been impacted by violence, on the other end, what are all the different systems and opportunities that could have come in as a touch point to reduce retaliation, stop an incident from escalating, and then something that is often lifted up, but that is super duper important, and it is the subservices. And that is easily explained by making sure that in that whole ecosystem where you have the outreach, reentry, your Office of Violence Prevention, interruption, and mediation, that those services that help folks with their just basic needs are present. Because you will find that a lot of the things that are going on that are negative in nature and community is because people are dealing with mental health issues, the result of substance use issues, housing, food, employment. So the things that many of us take for granted, often folks who get entangled in systems and negative behaviors and put themselves and others at risk because they want to be safe, healthy, and hopeful. At Cities United, we look at public safety redefined in three ways: interrupting the cycle of violence, dismantling systems of inequity, and investing in infrastructure. So interrupting the cycle of violence, as you can see on the display, violence interruption, street outreach, crisis response strategy, a coordinated crisis response strategy rather, hospital-based intervention, diversion and alternative pathways, collaborative public safety funding models. A couple slides ago, I talked about near term. So right there, right? And so that is interrupting the cycle of violence, because if we can stop some incidences there, then it improves our outcome for a long-term violence reduction. And then also looking at dismantling systems of inequity, which is a tough conversation for many localities to have, because there are a lot of systems that were developed and designed to do exactly what they are doing, right? And they were not necessarily thought of from a healing-centered or a helpful perspective. Systems that don't look at whole family integration or reintegration, systems that only look at punitive structures or the enforcement of punitive measures, takes away, in many instances, the family support needed to be successful and to feel safe, healthy, and hopeful. It removes opportunities for employment. Looking at, or as an example of that, there's many cities across the country who have looked at their hiring practices and have made some tremendous strides in partnership with making sure that they are a city that helps folks find employment in a livable wage, so that they are not, again, involved in activities that may lead to recidivism and additional risk. And then investing in the infrastructure. So that's direct resources, right? Sometimes internally and sometimes externally, that work to build up the ability to reduce violence and redefining public safety. So as an example, I will pick on a community that is closer to my home, where they were investing in infrastructure internally and also externally with community partners. And so it was a wonderful job to provide funding to community-based organizations, because they were doing good work, right? But some of the organizations that were doing the work were operating on a shoestring budget, car washes and things of that nature, to get things done. And folks are volunteering and not getting paid, right? And so it was a wonderful idea to make sure that funding was made available to help build their capacity. There were also very meticulous consideration for also investing in their long-term sustainability. So if you're used to operating with $500, before we give you $50,000, we're going to make sure that you understand the entirety of the process. This may be the first time you have signed a contract. This may be the first time that you will have accounting measures or things of that nature at a larger scale, which comes with more responsibility. Investing in their overall capacity at the same time as giving them funding to do good work and often provide better services, and then also take better care of themselves as those who are the practitioners. The other thing in that is understanding and making sure, as local government, because I used to be the director of an Office of Violence Prevention, is making sure that while you're investing in that infrastructure, that your internal systems, finance, procurement, whatever you have, understands the complex nature of what these organizations are going through. And so making sure that they understand how important it is for contracts to be signed, for communication to be in place, and for payments to be made in a timely manner. Because now that you've invested in their capacity to do better things, turning that around to make sure that they're able to receive funding and other capacity building supports on a timely manner. So investing on that infrastructure both ways. There was a win in a community near me because they were able to look at the typical funding process for putting out a bid to put a roof on a high school. And it was the same as it was for a $10,000 grant for a community-based organization to do an event. Now that's a lot of work on the internal departments, because there's a site visit, walkthrough, and all of these other things that you have to adhere to for something that that requires so much money and so many resources and safety, right? But for a $10,000 grant that's being given to an organization that's going to support a basketball league or a small reentry program, right? You can look at making the adjustments internally in your infrastructure in educating your internal systems as well as educating your external partners who are receiving the funding to make sure that the things are not necessary or not becoming cumbersome for either end. So what is a comprehensive public safety plan? Earlier in the press conference, I said I was really excited to be here in Minneapolis and hear that you all are advancing a comprehensive effort. The comprehensive public safety plan is a written document. It's developed in partnership with community, internal and external stakeholders, and it also gives considerable engagement opportunities to those who are most impacted by violence. And so they are not hearing what is done behind a closed door by an office. They are at the table giving their feedback, building relationships, and they're also in the same time helping to advance the knowledge of what this plan is in community, because that provides a checks and balances for internal and external partners. There are publicly identified goal owners and an accountability structure, because your comprehensive public safety plan, while you want it to be successful during a term or an administration, you want it to be something that continues beyond a term or an administration. And so we work to build the plan into a strategy that ultimately informs the ecosystem. And that strategy and informing the ecosystem, you'll hear our other partners who are presenting today talk about it, and the utilization of data to make sure that you're identifying the appropriate strategy and the correct deployment. So the comprehensive public safety plan, it shouldn't be written in pencil, but it should be something that your community is looking into updating and advancing as things change. You want to report out on your successes, you want to report out on your opportunity, the things that you've learned, and you want to make sure that you're tracking the data and that your goals are updated so you can show the progress internally and externally. When communities come to the table to do this work, I think it is a wonderful feeling to say that we picked this goal in partnership. This is what we're tracking, this is the data we're getting back, and this is where we're going, or this is the adjustment we need to make because some things have changed so we can continue to advance our goals. It is also accessible, and it looks at how you redefine public safety by integrating it into structures outside of typical public safety. It shows in a living document how all of these different components and pieces can work well together. And while everyone is playing their role and being a support in the other roles, it really shows how you can alleviate unnecessary pressures or expectations for components of public safety that were not designed to do everything. And so I will now pass it on to Shantae with the National Institute for Criminal Justice Reform.
Thank you.
Welcome.
Thank you so much. Good afternoon, Chair Chavez, Vice Chair Wansley, members of the committee. My name is Shantae Jackson. I am the director of the National Offices of Violence Prevention Network that sits inside of the National Institute for Criminal Justice Reform. Prior to taking this role, I served as the founding executive director of the Baltimore Office of Neighborhood Safety and Engagement. For the purposes of our conversation, when I say OVP, I'm talking about Offices of Violence Prevention, which can also be called things like Offices of Neighborhood Safety and Engagement, Community Safety Offices, Offices of Community Wellness, a whole host of things. Know that I'm going to be using the term OVP or the acronym OVP just to shorten that conversation a bit. What you're looking at, unfortunately, is an outdated map, but fortunately for us, the membership has grown, right? So you're looking at members of our national learning community of local, state, and federal offices of violence prevention. And so we're talking about the White House Office of Gun Violence Prevention as a network member, about 11 of the 12, I'm sorry, it's 15 now, of the 15 state offices of violence prevention, with the balance of our 75 offices being local jurisdictions. This is my first time standing before this body. I'm hopeful that it won't be my last time. I do want to share with you all that you can always depend on me to be honest and candid, and to answer any questions that you have directly. So what I'll share is that the Minneapolis OVP is a member of the network. I'll also share that unfortunately it's not an active member of the network. We would absolutely want that office to become an active member of the network, as is your sister city's OVP in St. Paul, who I personally provide technical assistance for with my team on a biweekly basis, along with a whole host of other jurisdictions across the country. So as we think about the role of offices of violence prevention, really they're founded with the premise that public safety has to be addressed through the lens of public health. That for too many generations in our country's history, that we over-relied on policing, prisons, prosecution for predominantly black and brown neighborhoods, instead of truly addressing public safety as the public health issue that it is. And I'll digress here a bit, was really excited about the presentation that your EMS team performed, especially after hearing that they're partnering with folks around mental health response. We are seeing that become more widespread across jurisdictions that we support within our network across the country, and would recommend to you all that you even start to give some thought outside of the mental health space. Around how you can better deploy your EMS resources, your local law enforcement resources, but leveraging community-based and behavioral-based resources as well, to lean into this approach a bit more deeply. OVPs are responsible for doing what I call is standing in this gap space, standing as the bridge, the convener of an all-of-government and community-based approach to public safety, where we see sustained reductions in violence across the country. I'm going to tell Baltimore because it's home. We're down 36% year to date this year on homicides and non-fatal shootings, and was down 20% last year. And so seeing year-over-year successes. Indianapolis, a whole host of other places that I could name, where we're seeing those successes play out is where we're seeing an integrated approach to public safety, one that understands that law enforcement is necessary, but one that also understands that you can't do community violence intervention without community-based organizations. And making sure that those are working individually in silos, but also working at points of intersection where it makes the most sense. As I think about something that I think Director Cotton mentioned during the press conference with regard to what your public safety outcomes look like prior to the pandemic, and called to mind what your population count is, it brought to mind Oakland for me, which is a member city of our network. And while the demographics are slightly different, the population count is about the same. I would say prior to the pandemic, they also saw some serious reductions in homicide, pretty similar to those that we're seeing here. And then during the pandemic, a hiatus, if you will, was taken in Oakland as it was here around your gun violence intervention strategies, around your community violence intervention strategies. And what we know to be true is that the mayor of Oakland, the city council of Oakland, has said, yeah, we got to start again because it was working before. And we need to do the things that are proven to work, and not just proven to work in the short term, but in the long term. We do know that GVI and CVI, when combined as strategies, have the potential to reduce homicides and non-fatal shootings by 30 to 60% over sustained periods of time. Offices of violence prevention are also responsible for serving as conveners and coordinating that whole of government approach, as I mentioned before, being the coordinators of comprehensive and data-informed planning. As someone who, prior to stepping into this public administration life, served as a community-based organizer, and even before that, about 2 years in the corporate sector as a data geek. I am a former database administrator, coder, project manager. I've got a deep belief in data-driven decision-making. both internally and externally. And so you'll hear me mention numbers a lot, but you'll hear me mirror those numbers with stories. Because we've got to be thinking about the people and the real results, the real outcomes, the real impacts that the work associated with community violence intervention and gun violence intervention is having in people's lives. So want you all to be thoughtful there as you think about the measures that you want to track. It's not just about the inputs. It's not just about the outputs. It's not just about the efficiency measures. What percentage did homicide go down? It is also about are we moving away from maintaining to sustaining? Are we moving away from surviving to thriving? Are we moving toward equity as it relates to opportunity in our communities? And at the end of the day, when we leverage the resources that are part of the CVI ecosystem, it's a huge contributory factor to that. So the last couple of points on this slide, with regard to OVPs, they are also responsible for funding and supporting community-based organizations and community-led efforts in equitable and strategic ways. A couple of things that I would love for you all to think through, especially as it relates to community-based organizations, is funding and evaluation, right? So marrying this data with funding. In many jurisdictions, funding happens on a one-year clip. There are only annual contracts. And those contracts are often based in a reimbursement model where you've got community-based partners already operating out of their pockets in order to get the work done. The best practices that I share with members of the network is that we should be aiming toward 3-year funding contracts and biannual evaluations. Right? So evaluate, bring in an external academic institutional evaluator every 2 years, but fund your programs for 3 years because the evaluation will carry into that 3rd year, right? And at the same time, you're giving your community-based organizations a couple of things, a level of stability, right? Year over year, a lot of folks in the CVI space across the country are concerned about whether or not they're even going to have jobs at the end of the cycle while they're waiting for reimbursements that from a procurement process can be anywhere between 60 days and 18 months. I'd also recommend things like looking at best practices as it relates to your reimbursement model. We are seeing jurisdictions in New York City, in New York State, in Baltimore, and a few other places where a certain percentage of funding is allowed up front when a contract is signed, so that community-based organizations are then submitting receipts and then not being reimbursed until after they've hit that minimum. That's become a best practice because of what I mentioned before around folks already operating from a deficit frame and then needing to wait, unfortunately, for outdated city procurement systems. I'm someone who had to work with a finance team who was working as fast as they possibly could, but we went from funding 12 community-based organizations to well over 30 as Baltimore grew out its CVI ecosystem. So the last note that I'll make here is that there are some offices of violence prevention who stand in the gap in another way. And you all will need to decide with your partners on the executive side and on the community side and on the agency side whether or not this makes sense for Minneapolis or not. But there are some jurisdictions who just simply don't have enough community-based organizations to do community violence intervention work, and as a result, they absorb some of the direct service work on their own. That would obviously involve a level of staffing and funding associated with that staffing, should that need to be the case. There are also some jurisdictions that have a hybrid approach, and so they fund community-based organizations and they fund agencies, OVPs, to do work in that space as well. So Sunithia showed you all a version of the CVI ecosystem slide. I'm sharing one that essentially has the same components in it, but is meant to be visually different on purpose. And so the way that we envision the CVI ecosystem is very similar to how we all want our medical systems to work. So I'm going to share a moment very transparently here. I am someone who has multiple sclerosis. And as a result of having multiple sclerosis, I've got a lot of doctors. They're all within the same medical system, though, right? And so as I think about what it would look like for someone who's at the highest risk of gun violence, either being a perpetrator or being someone that's a victim, they don't want to feel like, number one, it's going to be difficult to get them in the room anyway, so that relentless outreach is necessary. But once you get them in the room, they've got to feel like every single member of the CVI ecosystem has been talking to each other, and they don't have to tell their story over and over and over and over again. So while they aren't patients, they are participants or clients or whatever you all deem them to be, it's critically important that as these gears turn into each other, because there isn't just one way, as these gears turn into each other, it feels like this participant is getting total care from a singular integrated provider. And that's what a healthy ecosystem looks like, where you all are capturing data, where you're sharing the appropriate levels of data with each other so that you're providing holistic care in ways that really lead to the results, outcomes, and impacts that we want to see for these high-risk individuals. The last slide here is a whole lot of words, but I would say that it provides a list of all of the types of technical assistance, training, research, and analysis that we perform for partners across the country, and would happily step back into providing the same level of support here in Minneapolis if given the opportunity. Thank you.
Thank you.
Well, good afternoon, everyone.
Welcome.
It's always great to be back in the great city of Minneapolis, my home city, and glad to be here with you all. I'm Sasha Cotton, for those who, well, I think I know all of you, but I'm Sasha Cotton, the Executive Director at the National Network for Safe Communities at John Jay College, and I'll actually be transitioning our presentation into the format where we talk specifically about some of the programmatic work that has happened in Minneapolis, either past or present or sort of intermediarily. So I'm going to be talking about the group violence intervention, and away we go. So the group violence intervention is an operational approach to violence prevention, and it's really intended to build trust between community and criminal legal systems. Importantly, we work with prosecutors, we work with local law enforcement, we work with federal partners, but we are also really focused on engagement with community. Enhancing legitimacy is also key and critical to what we do. We know that communities need a law enforcement system, they need a criminal legal system that serves them, but they need it to operate differently than it has in the past. And in order for it to do so, it has to have legitimacy. And so that legitimacy comes from expectations being met, it comes from serving community with respect, and it comes through partnership with community agencies as well as community members on the ground. It's based on the central fact that communities themselves are not inherently dangerous. And that is really a result of looking at the data. According to the data in most major cities in the United States and really abroad, it is about 0.5% of the overall population that is driving the violence in most major cities. That is a very small number. And we were here and did a data analysis last year for Minneapolis, and that is true here as well. So if we can identify those people who are most vulnerable and susceptible to using violence and focus our attention on them versus blanketing communities with law enforcement or even resources, we can be finite with our resources and be able to really deliver the services and the law enforcement and prosecutorial responses needed to drive down violence and keep communities safe. We also want to recognize the power of informal social control. So I, for one, am very scared of my grandparents, and that is an informal social control. I am probably more concerned about their impressions of me, what they expect of me, and their accountability of me than I am of the criminal legal system, right? And so leveraging family members, friends, coaches, relationships that people have in community that they want to be accepted in is equally or more important than punitive measures like law enforcement and prosecution. So we really want to leverage saying, we don't accept violence here. It's not okay here. This community doesn't tolerate that kind of violence. We love you. We care about you. We want the best for you, but the shootings have to stop. And that message alone is very, very important. And it's important that systems and community members on the ground are saying that together. We recognize the trauma and victimization of people involved in violence, and we have to work to keep them safe. We have to work to keep them out of prison, and we have to support them as they make decisions to move away from violence. And lastly, our motto is that we want to keep people safe, alive, and free, right? At our best in community, when people are safe from harm, when they are alive, because only that allows us the possibility to work with them and have them build a life that's better. And really importantly, but also lastly, free from incarceration, free from being on paper, free from being involved in systems, including child protection and housing authorities, right? We want people to get the services they need that are offered in a way that is not punitive, but that is really about producing the best life outcomes for them. So our core GVI elements are a partnership that directly communicates core messages to group members. The group violence intervention is focused on groups. We use that term specifically over gangs because gang has a federal guideline, and also because groups are shifting across America and across the world. We are not necessarily seeing hierarchical groups that are affiliated with some national entity. We are seeing, like here, small groups of individuals who are participating in violence, carjacking, shootings, and sometimes have a nature of retaliatory violence towards each other. And so the term group is intentional. We bring together credible moral messages against violence. So I talked a little bit about that earlier. A genuine offer of help and support, and that needs to be as robust as it possibly can be, but it has to be credible. And that's where funding and the right staffing becomes really important. If the people who are doing the work can't credibly know that if they make a promise to someone that they can help them get housing, they can help them get employment, they can help them find safety, if the resources and the skill set are not there to do so, we lose legitimacy at the core of this model and everything else that we're doing, because people will not buy in, and we are talking about life and death. So people need to know that resources and staffing are in place to make this happen. And then a credible law enforcement message about the legal consequences for further violence. And this is really important and sometimes a touchy subject when we talk about violence prevention, because the group violence intervention is one of the only models in this framework when we're talking about offices of violence prevention that still has a law enforcement component. And we feel that that is incredibly important and has continued to bring good outcomes to bear when it's done properly. There is a difference between a threat and information. And the group violence intervention is designed to provide people with information about their legal consequences if they continue to be involved with violence. So this is pre-prosecution. Obviously, if we had credible reason to go in and arrest people, law enforcement are going to have to do their job. But it's important for people to know on the front end what will happen if they are arrested and charged with a new act of violence. So for example, someone who is a convicted felon and has a prohibition from being around guns, if we believe but don't have facts to substantiate a warrant, that people are running in crowds with guns, that they're in cars with guns, that they're around the wrong people and perhaps making the wrong decisions, letting them know, hey, if you're stopped with a gun, you're looking at a possible 5-year sentence. Hey, do you know this could be taken up to the federal level and you could be prosecuted and be sent very far away from your family and friends, right? Again, not threatening them and saying this will happen, but saying it could. And before you make a decision that puts you in that situation, we want you to know what's possible, and we also want you to know what's available to you. If you need help making different choices, having different opportunities, that help is available to you. But we also want to pull back the curtain on how the criminal legal system operates, because as someone who worked in probation and parole at the beginning of my career, far too often you hear young people, particularly young men and boys of color, standing before a judge saying, I did not know how severe the consequences would be based on my decisions. I did not know, because I've done a bunch of other things and I've gotten probation, or I've gotten parole, and now all of a sudden I'm getting a 10-year sentence. I didn't know that was even possible. And it's important that we're telling people on the front end how the system works and what is possible and what is likely, so that they can make informed decisions. We do that at the national network and with the GVI model in two ways. One that most people are most familiar with is a call-in. A call-in is a highly orchestrated thing where we look at the data and we invite group members or suspected group members into a space. We curate a wide range of speakers, usually including a mayor, the police chief, other agents from law enforcement at the federal and local level, as well as 3 particular community voices: a voice of pain, someone who has lost a loved one to gun violence; a voice of redemption, someone who has been involved with street violence and who is coming back to say, it wasn't worth it, I lost a lot of time, I was incarcerated, I was shot, don't make my choices. And then lastly, a voice of inspiration or hope, someone who is inspiring and saying, we need you, you're important to our community. We do that. Generally, sites are doing that quarterly or biannually, but increasingly sites are really dependent on what we also use, and they're called custom notifications. And it is delivering a same or similar message in community, sometimes at someone's home, in a probation office, in a church, at a coffee shop, right? Getting the person who we think is most likely to either be shot or to be a shooter and saying, hey, we are worried about you. We are concerned, you are important to this community, and based on what we're seeing, you're headed in the wrong direction. And you need to know what's possible, and you need to know what's available to you. So those custom notifications are really important. Minneapolis was doing a really robust amount of custom notifications, and we're eager to get you all back on track with that process. Again, GVI relies on partnership, and those partners consist of community members, social service or CVI agencies, and then local law and federal law enforcement. And you will see that at the bottom of this stool, we talk about our work as a 3-legged stool. These legs are interlocked. And because our partners already who have spoken talked a lot about the interconnectedness of these pieces, we really want to harness that. It is so important that these agencies are talking to each other, that they're working together, but that they are also protecting the integrity of what they promise to their participants. That means that local law enforcement can't be leveraging CVI and social service agencies for information about their clients. It also means that social service agencies have to give law enforcement the space they need to do their work and not have their investigations compromised. And so the need for respectful and honest, open communication and real guidelines and perimeters is important, and that's a role that offices of violence prevention generally play. We urge agencies to have their project manager for GVI housed in an office of violence prevention. That is the case here in Minneapolis, and the project manager is really represented by the seat of the stool. They circulate that information and act as a buffer to ensure that the way information is circulated is done in a way that protects all of the parties involved. Support and outreach framework is really, again, focused on keeping people alive and out of prison, providing that affirmation and relentless engagement. The folks that we're targeting, that 0.5% of the population, they are not always easy to find. They are not always easy to engage with. We need people from community with trust and who are willing to go out there and consistently be available night and day, right? Good outreach workers and support and outreach folks are doing this work not on a clock. Offering protection from risk, addressing trauma, and providing the big, small stuff. When we talk about the big, small stuff, we're talking about the things that are sometimes intangible. We're talking about being able to afford to buy somebody diapers so that you can get the buy-in to have the conversation. We're talking about sometimes paying a phone bill or a light bill, right? We know when people are cognitively distressed, they can't make good decisions. And so stabilizing that nervous system in order to have an intentional conversation about their safety sometimes requires an intervention that is creative. And so that's an important piece of the puzzle, that outreach workers and folks doing case management have the resources to pay for the things that they know are going to make the difference in the lives of the people that they serve. And then, of course, linkage to traditional services like housing and education and employment. Our framework, again, is around sustained engagement with an explicit focus on homicides and serious violence. This is an approach and not a program. If it's done right, all of government and all of community should be playing a role in this strategy, even if it's just being a messenger to say, if you are at risk, there are people who can help you. Everyone should at least know what's available to them. Based on the data, communication works. right? We know that in many of the cities, we see great reductions just from communicating. That doesn't mean people have received services or any kind of an enforcement action, but we are seeing 26.7% reductions in shootings for groups who have been notified by law enforcement and community members of their risk and the services that are available to them through custom notifications. This is just a statistics sheet about the impact of our work in Boston, New Haven, and Detroit. These are just a handful of the cities that we have worked in. We're in about 45 U.S. cities and about 10 international countries right now. And I wanted to talk a little bit about the history in Minneapolis. This chart points to some of the outcomes that we saw in Minneapolis pre-pandemic. As you'll see in red, group member non-fatal shootings had significant reductions once GVI was implemented. And I really sincerely believe not only with GVI, but with the other strategies that you'll hear about, there is the possibility to get back to those kind of record lows that we were seeing before. As far as the intervention is concerned, as of the beginning of this year, GVI had served over 432 high-risk individuals. Case managers are carrying a much higher caseload than they should. That's not all clients who are high need all the time, but they are people who actively are reaching out. There's a wide range of client needs, with housing and life coaching being the highest in demands. And now there is a juvenile implementation that is happening here in the city and in partnership with the county and this county prosecutor's office. That is looking at Hennepin County widely. Minneapolis has started to make referrals. So the police department is able to make referrals, and probation and parole are able to make referrals to do particularly the service element of GVI with young people who are at high risk of group and gun involvement. And with that, I will conclude my presentation and invite Dr. Williams to the podium. Thank you.
Thank you, and welcome, Dr. Williams.
So good afternoon. So I'm going to talk to you a bit about Cure Violence Global and our kind of space in the ecosystem. And it may kind of all sound the same. You've heard a lot of things, and it's easy to probably like confuse them. And so we started with Sunithia, who kind of gives you the big picture, and they help to develop like the blueprint for the entire city that is inclusive of each of our components. And so, you know, Shantae has the OVP, and Sasha has the GVI, and here we are with the kind of the focus of what people know us for is the outreach and interruption. But we are not GVI. But sometimes people call us all the same things, and so then you'll hear, you know, Highview has a different kind of component within the ecosystem, but we all fit together, and so there's overlap, and you may see some of that. And so just a little history about us and our model and kind of why we sit, how we sit. You know, we were created by a doctor who was trained in infectious disease, who worked for the World Health Organization. And so, you know, he focused on intervention development for things like cholera, tuberculosis, the AIDS epidemics, and came back to the U.S. thinking he was going to get a reprieve from epidemics, just to realize we had our own epidemic here. And what could it be like for us to apply epidemic methods to this issue we were having with violence in the U.S. in the 90s? And so started this work in Chicago, in, you know, one of the most kind of violent areas at the time, in one of the most violent communities at the time was Garfield Park. And in that first year of implementation, saw a 67% reduction in shootings with the application of the model. And so that work began to expand in that place. And this is back when we were doing direct service. And because of that work, you know, there was a lot of reaching out from different cities wanting to implement as well. And so you see on the side some of those beginning cities that we worked in with the implementation of the model. And then I believe in like 2008, even taking the model internationally, and then implementing adaptations of the model to different forms of violence. And so, you know, here in the U.S., we're very focused on community-based violence, but in other places, right, you have adaptations, war-based violence, political violence, human trafficking, gender-based violence. And so the point of that is just the understanding that addressing the issue of violence with a public health lens bears much fruit. And so really quickly, some of the highlights of the model, obviously, the public health approach. And so there is a scientific approach to violence reduction through public health theory and practice. The model centers community and builds capacity of the assets within those communities to address violence. There is the leveraging of lived experiences of individuals, so both victims and previous perpetrators of violence, to then give voice to what the solution needs to be in our communities that are most affected. And then there is the utilization of credible messengers, right? So hired community members, who many of which have similar life experiences to those that have been placed at highest risk for perpetration or victimization. And these individuals are trained and educated and coached in methods of persuasion and mediation and behavior change and norm change, which are critical elements to kind of limiting an outbreak of violence in various ways. And then, of course, the epidemic control methods, which is a big part of the strategy, which really requires that we analyze violence clusters to kind of understand the transmission of violence, right? So what is causing the transmission and why? And so we talk a lot about public health. You guys are maybe hopefully familiar with the fact that, we come from the perspective that this is a public health issue. And when we look at public health issues, right, there are certain kind of implications that we look to determine, like, why is this being considered a public health issue? And so when you look at violence, there are preventable risks, right? We know that there are risk factors for violence, and then there are protective factors against violence. And so there are things that make violence more likely in community spaces, and then there are things that can protect against violence that are very present. And so there are preventable risks for this issue. Obviously, there are effects on physical and mental health, right? So there's death and illness associated with violence. It adversely affects our, social determinants of health. We definitely recognize the disparities in health outcomes associated with violence. So there are particular populations of people who are more so affected by violence than others. And so we seek to understand why that is. And then, of course, the healthcare costs, which are outrageous. I think the last number I saw was like $8.7 billion in the U.S. each year. When you look at homicides in the U.S. And so it's very costly to not have control of violence issues. And then, of course, it acts as a contagion, and we'll talk about that a little more in a little bit. And so when we say, that violence acts as a contagion, like, we mean it literally. It's not figurative. There are population level characteristics that kind of make up what we consider an epidemic disease. And so here you see what are those things being clustering. And so when we say, clusters, here you see like this is cholera in Bangladesh. And then it's next to cases of gun violence in Chicago, right? And so where you see those deeply redded out areas, right? Violence is happening more in those areas, or the cases of cholera in those areas are more than in other areas. And so you're looking at why that is. And then it spreads also like an epidemic wave in the same way that the flu happens or COVID happens, right? Where there could be a time where nothing is happening and then all of a sudden there's a spike, and you're trying to figure out why it spiked at this season, at this time. Violence happens in the same way. And then lastly there is a means of transmission, right? People don't just wake up and decide to be violent. There's not a whole bunch of people that were born bad and violent. There's a learned behavior that happens, and most people are doing what they've learned. And so though it may be a newer concept as it relates to violence, epidemics and the idea of an epidemic is not new. We know how to address health epidemics. And so generally to stop epidemics, we engage in three major kind of key elements, and that is the interrupting the transmission, preventing future spread, and changing group and community norms as it relates to whatever the issue is. And so for us, some of this has already been talked about, so I'm going to determine which parts you guys can hear again. But essentially, there are key partners that need to be in play when you're implementing this kind of a strategy. There's the implementation agency, and that's generally the organization that we work with within the government, whether that's a health department, an OVP, a mayor's office, because their involvement is necessary. And they are generally the generator of funds for the work that's happening on the ground. You, of course, need your grassroots organizations. You need your CBOs, the folks who are actually going to be doing the work in the communities. And those organizations have to have relationships in the community. They have to be credible within the community for the strategy to work. And then there's the partnership and the buy-in that's necessary from other stakeholders, and so you have other agencies within even the government sector that are necessary for this work. You have school districts, hospital systems, social service providers, police department, and other community stakeholders where you can go back to Sunithia's image or even Shantae's image and, you know, her talking about all of these pieces when you're dealing with an individual who kind of transcends different systems. So much easier when everybody is on the same page, when you have a school-based counselor and maybe you have somebody in the juvenile justice system that you're having to deal with, and now you have a community case manager or violence, right? So all of these people should be at the table for the ease of service for these individuals so that they don't get lost in translation. Oh, and not forget the adequate funding because it costs to do this work, right? And so when you look at what it looks like to implement the model on the ground, and you're talking about the work that is done by our credible messengers, AKA violence interrupters, outreach workers, peace workers, whatever they're called in your jurisdiction. Some of the first things that they do, and this is the work of really violence interrupters, is preventing retaliations, mediating ongoing conflicts, and then keeping conflicts cool, right? And so when there is an instance of violence that happens, it is their job to figure out how to get in front of there being any type of retaliation on account of that instance of violence happening, right? And so they show up to where an instance happens, whether it's in community or in a hospital setting, as you'll hear, and they're really looking for who's talking about what, right? Or calming down family members or those who may be in association to the event that's just happened. Sometimes there are random disputes, you know, in community sometimes, being in relationships. And so it's their job to kind of know what's happening on the ground and being present in community to be able to engage with those that, you know, they're hearing the information about. And again, this is why it's super critical that these individuals have the highest level of credibility, because you are engaging with, right, a population of people that just, they don't talk to everybody, they don't trust everybody. And because this stuff happens like this, there's not a whole lot of time to like build all of this rapport, right? Like you already have to be credible coming in. And so from there is the identifying and changing the behavior. So once you identify the individuals and individuals that are willing to work, the work of the case manager really comes into play here. As you're spending time, as you're determining, you know, and you're making goals, and you're trying to get them to do something different, and you're trying to get them to think differently about how they've been engaging. And this is critical and important because sometimes this is where we lose when people are saying whether or not something is effective. At the end of the day, if they're not shooting anybody or killing anybody, it's effective, right? And so whether or not they decide they want to go to college, great if they do, and we're still happy if you don't, right? Whether or not they want traditional employment, all of those kinds of things that sometimes get added on, and sometimes they are. You will see these outcomes, but like you have to consider the things that you don't readily think about in your head, right? This is an individual that runs with a certain crew, and he's out on the corner 7 days a week. Now it's 4 days a week, right? Now he's spending more time with his case manager, the outreach worker. He's gaining the rapport. He has the ear to help this individual change his behavior. That's a success, right? And so like those are the kinds of things that end up getting documented within the system, and is still indeed a great success because they're changing how they're engaging in violence, which is what we care about. And then the larger picture, right, because public health is concerned with transforming populations and communities. And so it's not enough just to deal with the individuals themselves, which is a work within itself, but you've got to deal with the cultural norm of the space in which they exist. If violence is normal, that's why the response is the way that it is. So how do we send and spread a different message, right? So the public education and the campaigning around anti-violence, and the teams being out so that people know who they are and know what they stand for and know what community can come to them for. And they're getting to know the local business owners and the general community and create events to bring people together, to share information. And they also do the shooting responses. And so there's should be a response after each shooting to kind of denounce that happening, right? Like, we are not in agreement with this happening in our community. This has to stop. And it's just kind of this over and over message that folks get, that it is not okay to be violent. It is not normal to be violent. We have to do something different. And then lastly is a slide that shows some of the evaluations that have been done on the work. And so there have been, at this point, I think 22 in all, studies, reports, evaluations on the effectiveness of the model itself. I do know that there are 8 specific evaluations that were independently funded, independently conducted, multi-site, multi-year, mixed methods, scientific evaluations to show that, the model works. And, you can see between 30 and 70% reductions in shootings and killings. And so there is benefit to having this type of strategy operationalized within any larger strategy that you guys developed. And, we're just excited to be here and be a part of helping to implement this here.
Thank you so much. Welcome.
Good afternoon. My name is Juar Barnes. I serve as Senior Advisor for Community Practice at the Health Alliance for Violence Intervention, otherwise known as the HAVI.
Hi, everyone. I'm Josephine Pang. I am the Senior Manager in the Communities of Practice Division at the HAVI.
And we're standing as 4 shoes filling up the 2 shoes that our Executive Director, Fatima Lauren Dreyer, would fill. She was here, but she's away on maternity leave. So we're excited about that. Just to begin, a brief history. In 1994, an organization in Oakland chose to create a hospital-based violence intervention project. And that project immediately began to expand. Eventually, there was groups in Milwaukee and then in Baltimore that began to move this project. By 2009, there was a huge event that happened in the Bay Area where 30 leaders from around the country came in representing 7 organizations. And Since then, the organization has expanded to the fact now that we have 70 organizations around the country that we have active in our program, and about another 30 or 40 emerging programs around the country right now. So, so some of the things that have happened, the way to explain hospital-based models is that there are three ways that it operates in the community, and it confuses some people sometimes. First, there's the hospital base, where a staff is like directly, completely inside of a hospital, and the hospital has community partners engaged for training, referrals, and consultation, but the management of the hospital, the structure of the hospital completely owns the project. Secondly, there are hospital-linked projects where CBO has a relationship and they may have an MOU, and there's a lot of accountability connected, but that group will be able to go into the hospital to do bedside services, to follow a client all the way through, to have access to the data, and the relationship with the hospital is very engaged. And then a very common practice is hybrid, and sometimes the hospital-linked and hybrids look alike, and so it's very interesting. But HBIP staff are housed in both the hospital and in the CBO, and it requires a clear MOU is a very important type of approach to that, and supervision, cross-training, and communication practices are very critical because there's a very strict guidelines, obviously, that hospitals have that oftentimes CBOs don't have, and so it becomes very important that we operate in that mode. I should say this, as I talked about how the HAVI had grown and expanded, there was a set of ideas that happened across the HAVI that in that beginning process before we got to this process that really began to change the landscape. And part of it was just the way that the HAVI grew itself. In 2018, the HAVI, then known as the National Network for Hospital-Based Violence Intervention Programs, a lot of letters, had just a few people that were involved, and then it evolved in 2018 to an actual organization. That's when the HAVI was actually born as the HAVI. Hired the first executive director, Fatima, and from that point on, there were about 3 or 4 people who worked there. And I should just say this to bring some clarity. In that time from 2018 until this time, there now have grown from about 4 people to nearly 40 people on staff, so it has grown exponentially in those years. In that time, there's also been a lot of processing about how it works and how it moves. And so there are several things that HAVI does. First, there's intervention, which begins with a brief intervention in the emergency department or the hospital bedside. This is super important because it creates that potential beginning relationship where hospitals have this opportunity, at least the HBIP has an opportunity, to find something, to connect with someone early on in the process, and then have the opportunity to follow that person through. Then care is what follows that. Intensive, long-term, community-based case management services in the months following the injury, which often involves all the organizations that you see behind us. Then there's follow-up services, crisis intervention, linkages to community-based services, mentoring, home visits, follow-up, and usually this lasts. I remember years ago I worked in a hospital before it became the HAVI, when it was still all the letters, and in Indianapolis, and one of the things that we found was this could last 18 to 24 months, where when somebody gets shot or otherwise injured, we just follow that person for a long time to manage, long-term case management, and they're provided by culturally competent frontline workers, otherwise known as credible messengers in our field, and from the same similar communities and same clients they serve. And then the addressing the social determinants of health, which you've heard here on several occasions, elevate the issues because of the fact that hospitals are often viewed, and oftentimes are, ivory towers. The HAVI has engaged deeply in equity work. and really within our trainings, within our development work, to work on the fact that we have to address not just determinants of health from the people that come through the door, but have an understanding of that by the people who are in the hospitals. So that's part of our work, revolving door violence while addressing inequity, and we build partnerships with communities of survivors of violence. One of the things that's super important, I was listening to my colleagues, and I was thinking of St. Louis with Life Outside of Violence, and every time they have a problem with someone who is come through their program, Life Outside of Violence is a hospital link project, and when they have a problem with someone come through their program, they immediately, and that person is like in danger, they contact the CVI. They contact Cure Violence. Could you follow this person, connect with this person? Could you see what's going on in the neighborhood? So these relationships are very intricate and very engaging and very involved. In Indianapolis, the GVRS project there and what's happening at Eskenazi Hospital, those relationships are critical and make it happen. So it's all interrelated and happening together on a day-to-day basis. We have very specific goals. Our goals are to promote individual and community healing. So the people who come through the doors at that moment are very vulnerable on all levels. So to connect with that person, oftentimes even our surgeons are engaged deeply in the projects and are part of the team, because everyone has to understand that this person now is at danger. So there's protective measures that happen from the moment they come into the hospital. So we talk to emergency staff. We deal with our doctors at our conferences and our training and our TTA, and also involve the trauma surgeons and everyone involved, so that there's a way that a person is managed and handled when they come through the door. And then all of that helps to reduce retaliation and re-injury and arrest, because we also are dealing with families who come through the door, because when they come into the hospital, everybody's coming into the hospital. Everybody is there. And then to stop the cycle of violence and trauma ravaging our communities, when people are really addressed at that moment, when they're at the most vulnerable, that's the biggest opportunity to have someone hear and also think through what their options might be. And then to help those affected by violence and healthy, productive lives. And then one of the most important things that we have that's part of our work is on our policy side, and she'll talk a little bit about that in a minute, my colleague will, to address the root cause of violence and despair, racism, structural violence, and inequity. And that means from a policy perspective, from our policy department with, that's run by Dr. Kyle Fisher, all the way to the people that work on the ground in our training technical assistance team. So that brings us to the reason why it's so important. It's so important because of what I said earlier, because these are very vulnerable moments, not just for the victim, but for the family and for those that are all around. So hospitals are a prime point of contact to reach people injured by violence and those who might retaliate. We know that typically hospitals discharge people injured by community violence back to the same social situation from which they came. And we know that as a result of that, 45% of those people are re-injured. And sadly, when they're re-injured, it's usually more damaging that time than the original time. So HFIPs leverage that time when survivors are at the most vulnerable and dig deep on relational pieces and dig deep on relationships, and to open an opportunity for intervention that may involve the people in the hospital itself, or in many cases, the people who deal with the CBOs that are connected to the groups that are also in this room.
Thank you, Gerard. Hi, folks. So I'm just going to do a quick recap of everything that all these amazing people have already spoken to. So the hospital-based violence intervention programs are a critical component of CVI ecosystem. It complements all models, and every program, I think it's important across every city, operates differently, right? Whatever their kind of the location and how that ecosystem is already created, they are able to be flexible, adapt, and fit in a helpful and collaborative way. Core to it is always a trauma-informed care that includes the racial equity piece, which is key across all the ways that it engages with other models. And Folks have referenced this, right? But HFIP fits well with the GVRS models, with the GVI models, and with the CVI ecosystem. And we just want to acknowledge that all models are valid, and some operate better in different cities, and there isn't a cookie cutter kind of template for that we encourage people to follow. It's really know your community and build it from the ground up. The other piece too is that we want to acknowledge that institutions cause harm. All institutions cause harm. The collaboration between violence prevention professionals is a key component to the success of the CVI ecosystem and HFIPs, because what they do is create and maintain a mutually respectful relationship. We want to emphasize that the role of a VPP is not to solve crimes, it is to stop people from being harmed and killed. So VPPs are not informants. Doing so, expecting so, will cause people to be harmed. Their role is to be in the community and have mutually respectful relationships and to focus on the health and well-being of their neighborhoods. Sometimes that means a one-way communication. Again, I know that's difficult sometimes for folks to understand. It is a nuanced conversation that is happening all the time. Also, we acknowledge that the law enforcement communities across the U.S. have histories of committing violence against not only the communities of color that we're trying to support, but also the VPPs who are also coming from those communities as well. So here are the strategies that we employ to, as an HFIP, to support the larger CVI integration and ecosystem. So we focus on the highest risk individuals, and that criteria includes justice-involved patients, and also folks who are being held or arrested. I know historically that has been a point of contention, but we know that we want to focus on reducing harm. And we focus also on obtaining consent. We always get consent from our patients and clients. And this data is used to inform program inclusion criteria that is flexible and adaptable. So for example, many programs might start with an age restriction, right, 18 to 35. But as time goes on, they might see that they're getting folks who are younger, right, or older than that, and they will expand. We also use this data to share with public health. It's deaggregated information, just so that we can inform this piece, right, about the fact that there are hotspots that we want to focus on. And Shantae, Sasha, Sanithia, and Dr. Williams have repeated this, right? It is relentless outreach and engagement, and that starts at bedside. If folks are willing to speak with us, even if they initially decline, we are respectfully, repeatedly asking them during their stay. And then working through MOUs and respectful communication and collaboration with our CBOs on how to follow up with this person. Do they need more support? Are they wanting it now? If not, that's okay. And the purpose is to address retaliatory and cyclical violence, right, at the primary, secondary, and tertiary. So that's interruption prevention and overall community safety planning. And being present. So I just want to uplift our local HFIP, the Next Step program that's operating out of Hennepin Healthcare. We have Kentrell here with us. They are in the community, attending fairs, being in neighborhoods, going to roundtable meetings. They're meeting with their local CBOs, informally and formally. They're in contact with their local Office of Violence Prevention. They're a part of the mayor's office when there are convenings. They're working with the public health departments. And this last one, I think, not all states have anti-violence coalitions. We encourage people to create those and build those when and where they are absent. I also just want to uplift this bill as well. So the House Bill HF 25 and the Senate Bill SF 524, our amazing small and mighty policy team led by Dr. Kyle Fisher. Dr. Kyle Fisher worked really hard to pass this in 2003 with the support of Representative Cedric Frazier and 23 other representatives to get $71 million out the door over the span of 2 years. So I know some of that funding has been released. We're hoping the rest of it will be, and our local CBOs can access that. And then lastly, here's a QR code. This is an amazing website. It is periodically updated, and it includes the profiles of 50 cities across the U.S. It gives really great information about the estimate about the high-risk population that exists, budget recommendations, and templates and job descriptions for CVI staff and resources, as well as OVP roles if those don't already exist within those localities. And that's kind of the rest of it. I hope I didn't speak too quickly. Thank you so much for your time.
Thank you so much. We really appreciate this thorough presentation. I'll check to see if anybody is on queue, if you have any comments, questions they would like to make. I'll pass it to Councilmember Ellison.
Thank you, Chair Chavez. Just had a question, first of all, thank you for this work and thank you for this partnership and thank you for this presentation. This is work that I've been really passionate about in my career and have wanted to see, become advanced in my time in office. And there are times where I've been really encouraged by the pace at which we're doing this work. And there have been times where it's felt like to say that the work is advancing almost feels like an overstatement, right? Somehow, because it feels like it's not advancing. And I was wondering, what is the current state of our partnership with the city? What's the current state of the former partnership and contract with the city?
So that question is going to have to be, earlier the councilwoman answered that question. I can speak for the organizations present that most of us are here in new leadership roles. You want to come up?
I was just going to say, we're in.
Yeah, I'm making you on mic.
We're all partners, but separate. I know we're in negotiations right now with the. Yes, I keep wanting to call it the old name. For our contract, I think it's a 3-year contract that they're proposing, and so that is like in queue to be approved, I believe, by you all.
Great, yeah.
We recently have finalized a contract a few months ago and have resumed some intentional work with the Department of Neighborhood Safety and are in the process of providing technical assistance. My team will actually be back here in late August to provide some training on getting the model restarted here.
That's definitely.
Okay. So the National Institute for Criminal Justice Reform does not currently have any partnerships and a current contract. Cities United does not either.
Okay.
But previously worked in partnership with the office when Sasha was the director. And just really briefly, our colleague from the Javi lifted up an outreach organization. We also want to acknowledge Touch Outreach, and we Push for Peace, who are both violence interrupter teams, and we didn't want to lift up one and not make sure we gave love all over.
Absolutely. Well, thank you for laying that out, and I just think it's important for us to highlight that for the public. Obviously, my colleagues and I, are aware of that situation, but we really want to see, and I think this is a message to the public and to the administration. We want to see this work advancing, right? We want to see this partnership strong, and there have been times where, because of the turnover, right? Not because of, I think, anyone's bad intentions, but because of the turnover that we've seen, I think there have been times where the work has felt halted, or we're not sure what the work is rooted in anymore. And then I look at this presentation, and all those questions that sometimes come up for me are really clarified. Oh, this is what the standard's supposed to be. This is what the pedagogy is supposed to be. This is where the line is. This is what the bar is supposed to be set at. And I really want to see us as a city returning to that in full, in its completion. And so I hope that we can clarify that, and we can sort of reestablish, re-strengthen, rebuild, that partnership and trust as we move forward here, and get this work on track in the way that I think it should exist. So thank you, and again, appreciate the presentation.
Thank you. We look forward to renewing partnership.
Vice Chair Wansley.
Thank you, Chair Chavez. I just want to uplift first, again, much gratitude for every single one of you being here. One thing that I know I'm going to be in ongoing conversations and collaboration with Council President Payne right there, as well as my colleague, Councilmember Chavez, is the piece that you raised around how are we supporting this work on a sustainable and long-term basis. And specifically what we've identified as a continuous issue is the contract management piece and the way that it's not organized to support the longevity of our organizations or CBOs that are carrying out this work. And I know we received a presentation a couple of months ago where we heard that the model of staggering contracts is working just fine, and we hear that to not be true actually out in the community. And as you've highlighted, even in this presentation around the reimbursement processes not being conducive again to that longevity, and we're even having conversations now with BCR. You all heard them reference quite frequently our mental health response team. They presented in front of this body a couple of weeks ago and highlighted that they're pursuing an extended contract period because they are also and have been in the same predicament where this 1 year, 2 year cycle where I know Councilmember Ellison, I, and Council President Payne had to come in and save the day quite literally from their contract just ending and reinstating that partnership and contract with the administration support. And we don't want to continuously put these key partners in precarious positions, especially financially, and also how that jeopardizes service delivery because that means they have to pull people off the streets. There's not continuity in the delivery of those services, which means people are not getting the safety that they need, or the prevention of people being shot or killed is not also, in full execution. So that is something that I'm really looking forward to working with my colleagues on, and hopefully the administration, if they are willing, on how we can really reconfigure our procurement processes in a way that does support that longevity. And also, I'm really excited to look at ways in which the legislative department can also pursue our own contracts with you all to do that evaluation and research piece, because I know for sure there seems to be a knowledge disgap or a disconnection between our procurement and maybe neighborhood safety department leadership around what is actual best practices when we're setting up financial policies as it pertains to our vendors. And I get how to draw the line with, not putting ourselves in legal risk because we've had litigation and lawsuits around, contracts, but there is a way that supports best practices that gets the support to our organizations in the best way that they need. And I don't often think that's reflected, and that's what we're constantly hearing out in community where people have not been paid or people are not being put on the streets. And that's just trifling. So we don't want to continue with that model. And as like my colleague Cher Ellison, I think there is a number of us who are really excited to resume this work back in the way that it was, in 2019, where we saw some of those good outcomes, and go back in that direction. So again, I just want to say thank you all for being here. I know council will be relying on you all's expertise as we recenter this work in a more serious way. And I really look forward to working with every single one of you.
Thank you.
Nobody else is on cue. Thank you so much for being here. We really do appreciate the presentation, and it was very enlightening. Thanks.
Thank you.
All right, seeing no further questions, I will direct the clerk to receive and file that report. Our third discussion item is receiving and filing a report about MPD off-duty fees by Andrew Hawkins from the Auditor's Office to give that report. Thank you, Mr. Hawkins.
To pull a
Yes,
presentation.
Mike.
Or is this one on? Here, give me just a minute to pull this up.
Mr. Chair, if I may, as he's transitioning, I would like to be included as having voted affirmatively on the consent agenda item. I have been able to go through all of those.
Awesome. Thank you. Thank you, Councilmember Palmisano. If the clerks can please note that. Thank you so much.
Okay. Chair Chavez, Vice Chair Wansley, members of the committee. My name is Andrew Hawkins, and I oversee the City Auditor's Policy and Research Division. I'm here before you today in response to a staff direction on the potential off-duty administrative fee landscape and applicability to MPD's current off-duty system. To begin with the scope of review, this review focused on essentially a landscape analysis to look at what exists nationally across law enforcement agencies around the country. We looked at a couple other ones in North America just to see if there were any differences there. And we wanted to kind of pull from as many examples as we were able to, with the idea of this essentially serving to facilitate this conversation as it continues forward by providing a range of examples in terms of what other places are doing. The internal part of this process, as far as how do we fit these into the system that we currently have, was extremely challenging for a variety of reasons. Some related to timelines, some related to available data, and just the structure that we have, and sometimes trying to fit a round peg in a square hole. I do want to just make sure I note that out front. But again, in response to those challenges, one of the pieces that I did make sure to include in this was kind of highlighting some potential next steps that address the challenges that that we kind of observed as we dove into this work. Just to start off with the definition of off-duty work, which I think sometimes is in and of itself a point of confusion. So supplemental, and I actually pulled the definition from the 2019 police off-duty audit. Police off-duty work is defined as law enforcement work performed by an eligible police officer for another employer during times when the officer is not working on duty. Off-duty work does not include work arrangements with other agencies or city departments that pay MPD for officer time. Across a lot of jurisdictions, there is, again, confusion, kind of like I think we see here, between off-duty work, overtime work, which is managed officially through the city, and then again, one of the definite commonalities that I think we saw in a number of locations was that there's almost no differentiation between how overtime and off-duty are managed, which is, again, it's definitely a different situation than what we find here. Getting into off-duty cost assessment categories and reviewing some examples of what these assessment structures look like. For the purposes of this report, we identified 4 types of administrative cost assessments that can be tied into off-duty fees. Again, this is pulling from examples nationally. Some of these are more applicable, to the city of Minneapolis than others, but I did want to make sure that we cover them here. Administrative fees are going to define essentially any fee that's applied to recoup the cost of the administrative management or oversight of an off-duty program within a municipality. So this could be, we've seen a number of them where it's managed by the police department itself. We've seen other ones where there's consent decrees in place that require an external group to oversee and manage and administer the off-duty program, and that is funded directly through these types of fees. Next, we have vehicle fees. It's, again, fairly self-explanatory, but again, it's just the assessment to basically recoup the cost of the operation of any vehicle in an off-duty capacity. I do break down examples later, but this can apply to squads, to mounted patrols, motorcycles. I mean, there's a few examples from Canada where they charge quite a bit for bikes. Insurance fees, this was one that I think, at least in our current situation, is probably less applicable, but based on, again, local, state regulations, there are a number of agencies that provide waivers for entities that want off-duty support but don't want to cover the liability insurance. They can actually just pay into the department, who then provides an umbrella coverage from their own insurance policy. And then finally, we have the third-party management, which again, this is generally applied as an administrative fee. Where this is different from funding the internal kind of oversight and management is that there's essentially kind of emerged a cottage industry of third parties that are responsible for the management, and administration of off-duty employment on behalf of various police departments. Getting into some examples of cost assessments, just looking at administrative fees nationally, these examples were selected to sort of provide, again, kind of a broad range, and I think, if nothing else, reinforce that there's not really one standard approach to this, and how people are coming up with some of the costs can vary fairly wildly. Looking at Honolulu, their administrative fees are assessed on a per officer basis. Again, as additional officers are requested by an entity, that cost then goes down. This all is added to the total expense and payable directly to the city. Looking across the border at Milwaukee, It's just a flat rate of 10% of the overall costs. So for these ones, when an off-duty, like they'll fill out the request form, they'll establish the officers they need. There's this established compensation rate that's determined, and they add 10% onto that, and that's payable upon the payment of the contract. New Orleans, this one is, again, in a continuous state of evolution for reasons I can get into later, but theirs is a 15% of the total cost, or $5 per hour, whichever is less. Again, why they went that route, other than just to add some complication, I don't know, but that's just going to be added onto the top, and the same thing, paid with the contract. Charlotte, North Carolina actually has an interesting system. It's 25 cents per hour. Is their administrative fee. That's on a sliding scale that I believe is going to continue to go up over the coming years. It goes to 50 cents next year, and then I believe 75 the subsequent year. There is no deduction if there's multiple officers. It just gets assessed per hour and per officer. To provide some examples of vehicle use fees, we can look again just across the St. Paul. Right now, it's defined as $20 per use, which is assessed through a payroll deduction. I believe this was part of their recent kind of renegotiation of their off-duty structure. Looking at Boulder, Colorado, it's a flat rate per day. Doesn't matter how long it is. It's $55 for the use of a squad, and again, paid directly to the upon once the contract is paid in full. That's just included. Columbus, Ohio, is $25 per hour. Miami Beach is $3 per hour. Again, I want to highlight these examples just to show that there is no common way that these are calculated. I'm not sure, again, how much they're recouping for them, from those $3, but that's what it is. And then again, with Honolulu, they had a unique example where it's actually 67 cents per mile. So if the squad's parked, there's not an assessment that's going to be accruing. And then to provide some additional examples, I mean, just looking at everything from ATVs to canines to horses to boats to motorcycles. So if nothing else, just to reinforce that, it's adding additional assessments for the use of these this type of equipment for off-duty work is not unique. Now, getting into the history, challenges, and opportunities that are specific to Minneapolis. While this request was specific to fees and how the fees are assessed, it's impossible to have this conversation without kind of understanding how we got here and why our system exists in this, I think in the fashion that it does. First, any conversation around off-duty, the off-duty employment system, reform of the system, potential issues, somehow, always will come back to the 1995 injunction and 1997 settlement agreement between the city and the Police Federation. This contains a number of guidelines that were agreed upon, including the right to contract off-duty services. There were also a number of things in the settlement agreement that I wasn't able to determine whatever came from them, which was, there's a lot of language around a test program being implemented to, try out certain things that, may have improved the way the oversight of the program worked. There was also establishing an off-duty employment committee. Again, to that extent, I was not able to find out kind of whatever became of some of these entities. But again, understanding this document, which is included in the report, is critical because everything ends up coming back to this. Just to highlight some work from one of our partner divisions under the City Auditor's Office in 2019, in the internal, what was at the time the Internal Audit Department, conducted a review of off-duty work processes in MPD. There were 4 issues that were identified. Again, I want to highlight these just because these issues are part of the reason that it's very difficult to continue the conversation around, where do we fit specific fees into this system itself. As of today, I believe that 1 through 3 are still technically open. From my understanding, just through conversations internally and with MPD, I think that they might be fulfilled. It's just that it hasn't been resolved through the formal process with internal audit yet. And then I believe with number 4, around the use of squads, that one was resolved by essentially accepting the risk. Next, again, getting more recent, we have the 2023 DOJ report that conducted, again, a review of MPD's policies, procedures, and operations. One of the items that was highlighted in that report has to do with the off-duty structure and the potential impact it has to the supervision. Again, I just included some excerpts from it, just from the report itself, just to highlight the findings. There certainly have been other investigations from DOJ with a more significant focus on off-duty programs in certain cities. Again, that's where New Orleans comes into that comes to mind, but the fact that it's mentioned is important for reasons that I'm going to touch on shortly. To understand our current situation in terms of how this is governed, where the policies and procedures exist, this is established through MPD's Policy and Procedure Manual. They do have some existing process requirements to off-duty employment in its current state. That includes, again, approval of off-duty assignments, requesting permission to use a squad. There's a requirement that officers are signing in with dispatch upon the beginning of an off-duty shift and receiving a call sign so that they're available in the event that there is any like policing-related duty that they need to be diverted into. And then each contract that the city has, or not the city, each contract that exists for off-duty employment requires a contact within MPD that essentially becomes that contract manager. That individual is responsible for essentially the management, maintenance and oversight of that contract in its current form. Looking at the challenges, both just to the landscape itself, but also to the fee structure. Again, the guidelines, they've increased the tracking recently, which again is definitely a step in the right direction. But one of the issues that exists is that it's extremely hard with the current software that's being used to pull out aggregate data. You have to go across on a shift-by-shift basis and look at who is assigned to what watch, and then like go to the next one, put everything together. So I think there are some limitations. This is not that's not to say that it's anything. Where like deliberate, I think the challenges from dated software systems is not an uncommon problem in the city, at least in my experience. Again, another challenge. Well, there are multiple checkpoints through this process as far as how approvals sought out, who the conversations need to occur with, how do we do oversight of the contracts that are out there, what's happening. It's extremely decentralized. That creates a problem, just with communication itself. Further, there are some systems of record where some of these stages take place, but most of those systems don't communicate with each other in any way that's replicable. Lastly, while overtime assignments, are processed through the city, similar to just standard, payments and paychecks for policing work. Off-duty, the financial components of our off-duty system exist entirely outside the city structure. This has a number of impacts, but one of the areas where it gets complicated is determining, if there is any fee to be assessed, how is that fee recouped? Because it gets into employment issues where, can you charge somebody within the city structure for use of equipment where the money never entered into the city itself. So that's one of the items that I'm going to touch on here shortly regarding potential area where a city attorney opinion is going to be beneficial. It's not all bad. I figured I would end on an opportunity. I should express my gratitude to Public Works, Fleet Management, and Director Royston. They sent this over last night. That's something they've been in the process of working on, so I was extremely happy that they shared it when they did and that they allowed me to include it on short notice. One of the things that Public Works is currently looking at is determining an hourly expense for fleet vehicles. Right now, the way that fleet's managed is that if a department has a need for a vehicle, they essentially have to procure a vehicle. So for departments that only need intermittent use of them, if it's not, and I know there was an hour car subscription, but it's not really a functional system. So by determining the hourly expense, that will allow them to better use kind of a pool of vehicles that departments can use and then pay out on an hourly basis. Obviously, recognizing that there's applicability to the fleet that MPD is responsible for. What you see before you is, again, example calculation from Public Works, just on the hourly expense for the Ford Explorer squad vehicles. So after looking at the replacement cost, gas usage, everything, they came back with $19 an hour as their hourly fee. As I touched on earlier, again, it's a wide range as far as what people charge, but that does seem, fairly in line with what we saw in terms of what the average would be. Getting into potential next steps. So the city attorney is probably going to be the only step that's available before, we can really move forward on anything, just because I think there's a number of questions that have to be answered before, it's clear, what possible components, if you want to pull from other examples, and explore their implementation in the city, like what's going to be available. I think we need to know what, again, looking at the, injunction and settlement agreement, current structure, other laws, anything else that's kind of in that universe, it's going to be important to seek out an opinion. So whether that's on a specific item, whether that's on the broad applicability of the settlement agreement, I think that's something that the council needs to determine in order to move forward. Again, that could even include, looking at that $19 an hour. It's, like, is there a different avenue to assess that, across departments for, off-duty use? So I think there's a number of questions that council might have that need to be answered, again, from our legal counsel. The next step would be additional legislative directives. Again, and in whatever capacity we're able to support this, we're always going to be more than happy to be a resource for council and for the, like to assist the administration on research, anything of that nature. But this would be more focused, specific legislative directives to the administration on, the feasibility of a specific program. So whether it's looking at, like taking something from another jurisdiction and, we just want to see what this would look like here, or whether it's taking pieces from, like pieced together from a number of locations and kind of trying to understand what it would take to implement those in the city. This can also include, again, to the public works example, what does that look like as far as how would we expense, the use of vehicles for off-duty use, and then lastly, just with respect to the data, what would be, what would it take to have a better system, that can kind of increase the efficiency with which all of this stuff is managed and keep our data together. And that, again, could include, what would it look like to procure a third party to manage this? What would it cost? What would the impact to the department be? With that, I can conclude my presentation, and I'm more than happy to stand for questions.
Thank you so much for being here for the presentation. I'll first pass it to Council President Payne.
Thank you, Chair Chavez. First, I just want to say this is phenomenal work. And specifically, what I really appreciate about this is, I personally read that, settlement agreement from the 90s quite thoroughly. I read the DOJ findings quite thoroughly. I read the off-duty audit findings quite thoroughly. And yes, also thank you, Councilmember Palmisano, for your leadership in driving that audit. But seeing all those pieces come together, it's actually helping, you consume hundreds and hundreds of pages of these documents and you try to retain as much as you can, but the way that you've kind of overlaid all of those facts into a specific finding, and even like weaving in some of the work that you did on TNCs when it came to, different ways of estimating costs, I think is just like a phenomenal expression of how we can start using some of this good work that already exists within the institution and actually synthesizing it towards better policy making. And already I'm seeing real opportunity. Obviously, the kind of elephant in the room is we still have yet to hear from the Department of Justice. We know they weighed in on off-duty, but we don't know what that consent decree might have. We don't know how that consent decree would intersect with the settlement agreement from the 90s on this topic. So, but this gives us a really strong foundation to come up with some things that feel very tangible. And even just the idea of accounting for a $19 an hour fee might give people pause on overtime. And this kind of ties into also with the body of work we did last term on this committee around the buyback process and this distinction between buyback contracts where, a third party contracts with the city directly to have MPD as a presence versus off duty where they contract directly with individual officers. I see there's an opportunity to just have a better integration and management of their time, especially as I think about officer wellness and whether or not we're tracking their hours adequately. And so I'm just really grateful that you've given this strong foundation for us, I think, to improve some of these processes. So thank you.
Thank you. Again, if I can, I alluded to it earlier, and I feel like I never followed up with it. But as Council President, as you touched on, with the consent decree, we are still waiting on that. That's another area where obviously the city attorney is going to be, like the one to advise you on where we're at with that. The fact that it's mentioned in the consent decree, I did note that it's not mentioned as thoroughly. Again, like kind of in reference to New Orleans being one where it was a big section. I think that initially went in 2011. It's now it's now 2024. It's still in process of being resolved. That's one of the few examples I've seen of. Again, I don't want to imply that it's an apples-to-apples comparison, but just in terms of the decentralized structure that we have here. So, again, it would not shock me if there was some component that came out of a consent decree that, like generally it will require like some formalized, oversight structure for the administration of off-duty.
Thank you. And then we'll pass it on to Vice Chair Wansley.
Thank you, Chair Chavez. Of course, I want to say thank you to our policy and research team, specifically you, so Andrew, for getting this report completed and for providing clear examples on how other municipalities, including the one right across the river, how they've gone about instituting fees related to off-duty. I think my colleagues know this is something that I've been advocating for in terms of figuring out what legislative actions we can take to promote the regulation of a program that has been identified as being one of high risk and that has caused some very serious safety outcomes both for our residents and for officers themselves. So, I have spent like 2 years trying to figure out what those legislative actions could be. And when I first brought forward a legislative directive to understand those potential options around instituting fees, the administration essentially failed to provide any examples on how we could go about doing this work and recognize like they were unsure what those next steps will look like. And this report gives us a lot more clarity around what some examples are that we could pursue or consider as we're thinking about taking action. And I do want to note my office is already in conversations with the city attorneys around, potential next steps. And I do want to also reframe this piece around the consent decree, because I often hear about this in terms of like, oh, we got to slow our roll. The consent decree or settlement agreement is just like many of our other legal processes. It does not mean that the city can't bring proposals to the table. Similar to how we did with CCPO and said, let's figure out how we can bring a proactive, solution or proposal to address what was identified in the investigative report around, the mismanagement or the lack of effectiveness of our prior civilian oversight boards. We also have the opportunity to take proactive action as a city and say, and I'm pretty sure our partners at the DOJ or the Minnesota Department of Human Rights would love to see the city take proactive action and say, here's some things that we've already been considering. How does it look to like integrate this into our settlement agreements? So those are the things that I'm looking to, advance and showing leadership as it pertains to like the council cares about this work. And we don't have to wait until our partners at the DOJ or MDHR basically tell us what to do or tell us how to do our jobs, especially when we know this has been a long-term issue. And we actually have now, credible information and helpful information that can help us figure out next steps. So I'm really looking forward to working with our city attorneys to actually identify, again, those concrete next steps that we know is within our wheelhouse of authority to advance in the next coming weeks. I would really love to see a fee schedule be brought forward that reflects some of the, already bare minimum, widely understood expenses that are connected to our off-duty program. So I'm really looking forward to, keeping colleagues up to date on what that is and how we're, moving that work forward with collaboration with the city attorney's office. But again, thank you so much for this. This is, again, giving us more options on how we continue to advance this work around regulating something that our residents have been asking us to regulate for quite some time. So thank you so much, Andrew.
Thank you.
And lastly, unless other folks want to chime in, I'll pass it on to Council President Payne.
Thank you, Chair Chavez, and thank you, Vice Chair Wansley, for uplifting that point around the settlement agreement and the consent decree. I got a chance to meet with leaders in Oakland, actually, and we're very grateful to have our new director for civil rights from Oakland about, they're the longest serving consent decree right now in the country. And one of the elements that they really raised was that we should be looking at the consent decree as a floor, not a ceiling. And already in some of the work I'm doing around amending the CCPO, we've identified some conflicts between the language that we've agreed to in the settlement agreement and new authority that we could incorporate in CCPO as a result of the past legislative session. And I was originally pausing on making amendments in that space because I didn't want to conflict with the settlement agreement, but that trip was really eye-opening for me because the consent decree and settlement agreement, these are agreements between two parties, and if those two parties agree on making a modification that strengthens the outcome, then there's nothing that should prevent us. There's no judge that's going to say you shouldn't do that if the two parties agree. And so I think this is definitely one of those topics where even though we are waiting for the consent decree from DOJ, that should not necessarily be a barrier for us moving forward. And so I just wanted to uplift that point.
Great. Thank you, Mr. Hawkins, for the presentation. We greatly appreciate it. Seeing no further questions, I'll direct the clerk to receive and file that report. And lastly, we have our final item, which is receiving and filing a monthly report on the South Minneapolis Community Safety Center, the Lake Street Safety Center, and the work of Community Safety Design and Implementation Team. I'll invite Director Amanda Harrington from the Office of Community Safety to give us that update. Welcome.
Thank you. Good afternoon. Amanda Harrington, Director of Community Safety Design and Implementation with the Office of Community Safety. I wanted to start off by saying how excited I was to hear about or hear from our national safety partners. I am familiar with some of them. I was lucky enough to go to the Cities United Conference in Atlanta and the one locally, and some I'm just learning about since I joined the city. But I see a lot of commonality in the recommendations that they made and the direction that we're moving with the Safe and Thriving Communities report. I did want to do a little follow-up. Since the last public health and safety hearing, I had heard from some city staff and some community members about some confusion about the name of the plan that we're working on, moving toward the community safety ecosystem. And so I just wanted to clarify that I'm utilizing the Safe and Thriving Communities report as the plan. There's already general support from administration and city council on that plan, and it's a clear area of agreement in a system that doesn't always agree. So I don't want to mess with that. The thing that I actually most appreciate about that plan is that it doesn't limit us to thinking about police or alternatives to police. That old way of thinking is really limiting because it's not a dichotomy that we're working on. Our collective energy should be focused on providing the right response by the right responder at the right time. That's a quote from the Safe and Thriving Communities report. And that means we have to focus on the entire ecosystem, and how we talk about that work is really important. To launch in first to the safety ecosystem work, my team has been working on a dashboard so that we can keep community members apprised of the work that we're doing. The first dashboard will focus on the launch list. It will just be phase 1, and that should be up later this week. As we finalize the next 12 months of implementation, we will be adding information to that dashboard, and more detail will be available. We hope to have that first 12 months of the implementation plan done in September so that we can share that with everybody. We're currently meeting with department heads so that we can figure out what tasks are already done or what are they currently working on. And I've actually been really pleasantly surprised at the amount of progress that's happened since the report came out. I've spoken to this body previously about the 3 pilot programs that I've been working on with performance management and innovation. And I just wanted to add a 4th. I recently asked Performance Management and Innovation to start exploring how to increase collaboration or coordination of juvenile diversion, and then also increase deflection of juveniles from the criminal justice system. We have some deflection set up for adults right now in the city, but we don't really have a process for that with juveniles. I've also previously talked about city system developments that we're working on. We've started looking at some contracts to help determine the best program or software to consistently collect information from vendors that provide safety services. We want to increase analysis of service efficacy and increase transparency through dashboards, but to do that, we really need a consistent way of getting that information from our vendors. And so we've had an initial meeting with IT about this, and we plan on starting by looking at some contracts in neighborhood safety as well as the city attorney's office. Although we'll expand over time, there just are a lot of contracts. We continue the work with the Infrastructure Planning and Design Committee to flesh out the process to require collaboration and data collection regarding safety contracts. We'll be piloting that new process with a few departments in the next few months. And we've also been working to increase interdepartmental collaboration on community engagement. A really concrete example of that was the creation of a postcard-sized flyer that I'm hoping some of you brought out with you during National Night Out that points people to one place where they can find multiple safety programs and initiatives like Truth and Reconciliation, Minnehaha 3000, opioid work. That's another place where we'll expand that so that people don't have to do so much work, quite honestly, to get information about the good work that we're doing in the city. The Safe and Thriving Communities report calls out the need for increased collaboration between safety partners, and we started that in earnest yesterday with a convening of safety service providers. We had almost 100 providers in the room. We had folks from the city of Minneapolis, obviously, but also Hennepin County, Metro Transit Police Department, Parks and Recreation, as well as a good number of community organizations. I know we didn't get everybody, but this is really a starting point. I was really excited to see people say, oh, I didn't know that that organization existed. Exchanging business cards, or I guess what people do now is they exchange QR codes on their phone instead of paper business cards. But regardless, people were meeting each other and they were learning new things, which was exactly the point of having this first convening. It's not the end of the process, though. I know that. I said it to folks that were in attendance yesterday. The next steps are going to be having some future meetings that might be more specific. For example, we need to get together violence interrupters from the city and the county so that we can talk about the ever-changing community needs and make sure that we're more organized and collaborative on where the violence interrupters are working geographically and making sure that they're out at the right times. But we also have to continue to have these really diverse meetings where folks can meet each other and cross-pollinate. We can't just have everybody doing the same work at the table because they need to talk to people who can make referrals to them and they need to talk to people who they can make referrals to. Lastly, we are moving forward on creating a community advisory work group as suggested in the Safe and Thriving Communities report. I'm incredibly grateful to have received funding from the Minneapolis Foundation to support a community advisory work group that will be formed by Commissioner Barnett. Applicants for the work group will be reviewed by a panel of community members who will make the recommendation to the commissioner. We are going to be seeking individuals who have connections to historically marginalized communities, lived experience with safety systems, experience or expertise in specific areas of community safety, commitment to community safety, racial equity, and social justice, the ability to work collaboratively with people who have diverse perspectives, and an ability to represent geographic and demographic diversity that we have in this city. We expect to provide more information and post the application in the coming weeks. I only have a few updates about the South Minneapolis Community Safety Center. I had previously mentioned that we would be issuing requests for proposal. Those requests for information, the RFIs, close this Friday at 2 p.m. And I was able to confirm that the RFP for the architectural and design firm was posted, and that closes August 26th. So we probably won't be coming back in August for this city council to approve that contract. Looks like it's more likely September, but it's out there, which I feel like is progress. And then we've started working with performance management and innovation on determining what success metrics are and how we can gather that information once the center opens. Regarding Lake Street, we still expect to open that location in November of this year. 311 staff are in the process of interviewing applicants for the 311 customer service agents who will work at that site, and I do want to thank the City Council for funding those positions. It's really important that we have them in that site. I believe second interviews will be taking place next week. We are working with the City Attorney on a shared space agreement so that we have an understanding that's written with the community organizations that will be sharing space with us. And we continue to explore working with opioid service providers in that site. I believe there's a couple more meetings coming up with the project manager, as well as working on metrics for success in this site as well. After that brief update this time, I am available if there are any questions.
Thank you so much for that presentation, Director. I'll pass it first to Vice Chair Wansley.
Thank you, Chair Chavez. Director Harrington, thank you again for this recent update. I'm really excited to actually get this update, especially since this committee has really initiated a lot of engagement around both the Safe and Thriving Communities report and also the plan that's attached to it that outlines our 10-year vision to actualize it. So I did have a couple of questions, but I do know we're short on time, so I just want to document it as a staff memo for follow-up. So I did.
And I don't mean to interrupt you, Vice Chair. We have until 4:30, so we might have time. But
okay, is there any? Because I'll double check. Okay, cool. Well, we'll see what we can get through, and if not, I'll get to staff direction. So in regards to a couple of the items that were labeled as done, specifically the section labeled define leadership roles states create clarity regarding roles and responsibilities and decision-making authority throughout the system operating under the collaborative practice model. I just want to know if you could walk us through the details and flow of how decision-making is done throughout that system.
Yes, thank you, Chair Chavez, Councilmember Wansley. I had previously shared a organization chart, it might have been in June, at one of the PHS committees where I showed that the design and implementation subgroups actually make recommendations that come to the design and implementation team, which is the team that I had. We bring that information to the commissioner, and the commissioner ultimately brings that to the cabinet and to the mayor. So that's the flow of decisions.
Gotcha. Okay, thank you for that. And then under the define the future of the vision, it states that with the collaborative practice model described above, develop a vision for the future to provide overarching direction for the city's efforts to transform its public safety and health services. I just wanted to make it clear for the public, like where can people find the completed vision by the administration? I wasn't sure if that was like the same as like the Safe and Thriving Communities report in itself.
Chair Chavez, Councilmember Wansley, we have provided the Office of Community Safety mission and vision on that public website, and then we also have a more specific mission, vision, and values that have been posted on the website for the design and implementation work.
Great, awesome. And then as pertaining to the RFP that's gone out for the architectural and engineering services or design services, I know I've had conversations with you around, and even you came to a meeting in my ward around this, of how we're really thinking through the selection of services, because you talked about, or from the engagement, there has been proposals around a substance use facility or, other public health services that comes with their own specific licensing regulations and mandates. Sometimes that also comes with zoning regulations where certain centers can't be in a certain feet of children, and there's proposals of having childcare. So I did want to get a sense of, how will the RFP, or how you all are supporting whatever firm that's going to be selected, how are they going to be able to do the layout proposal in consideration of that? Because that sounds like something that maybe the administration on the executive side would have to provide in terms of like what those mandates are, those, ineligibility requirements, if we're talking about some of those public health services, and how that then intertwines with like the MPD side. So is that outlined in the RFP, or is it the expectation that the firm will kind of provide recommendations on how that could happen or coexist or be co-located?
Chair Chavez, Councilmember Wansley, I did not write that RFP, so I can't speak to what's in it. That the RFP is being managed by Property Services.
Oh, okay.
It is public, and so both you and I can read it, and I'm going to read it after this, now that you've prompted that question. I know one of the things that we are working with Property Services on, and one of the things they've been waiting for, is us to complete the request for information so that we can provide more clear information to the design and architecture firm about what are those services. I think once we narrow them down, that's going to help feed into the information that you're asking for. For example, if the RFI that makes the most sense is not that there will be a treatment center in the same space as a childcare center, then it's not going to be as much of an issue. It might be that an organization says, we want to have people in this site that can direct people to treatment centers back out in the community. Then we won't have a licensing issue. It's just a matter of how much space do those folks take up, and how do we build out spaces for collaboration.
Gotcha. That's great to hear. And then last, I know there's been ongoing conversations with a number of council members representing the 3rd Precinct around, support with the community engagement. So for instance, with the Community Advisory Board, can you share ways in which the council can be involved in that? And just knowing, Barnett, or Commissioner Barnett, is great to hear that he's going to be informing that process. But I think we've talked about, we are the first touch points with our constituents, and often, are engaged with the groups that are on the ground, maybe a little bit more so sometimes than the commissioner themselves. So it would be good to know how we can support this work group, and making sure, groups are aware how to apply and become active with that.
Yes. Chair Chavez, Councilmember Wansley, I appreciate that support that's been given and the support that's offered. Just like every other activity that I've taken in the recent past, I will provide updates to City Council through the regular emails, as well as providing links. In some cases, I've actually even written up wording for council member newsletters, if that's helpful. But I really would like your help in getting the word out to organizations and individuals within your wards about this opportunity, because I think that's how a lot of people hear information. I've said that at this podium before, that I've heard directly from community members, I found out about this meeting because I found it in a council member's newsletter. So we would absolutely appreciate you getting the word out to people and encouraging them to apply, because some folks might be a little intimidated to apply for something like that, and we really want it to be representative of our community.
Awesome. Thank you again, Director Harrington. All the questions I have.
Great. And there is no one else on queue. But I just want to say thank you for being here, Director Amanda Harrington, and for the update on the Lake Street Safety Center. I'm very glad that it's moving along, and I appreciate your work on making that happen. So, cool. So, seeing no further questions, I would direct the clerk to receive and file that report. And seeing no business before us, I will declare this meeting adjourned.